After IBD session, we will start over the last session of pancreas and lunch will be at 2 o'clock. The first topic of pancreas is long-term complications of acute pancreatitis, how to diagnose and manage pancreatic exocrine. For that, I would like to invite Dr. Parag Shah sir, Dr. Manish Agrawal sir, Dr. Anil Kulsreshta sir, Dr. Nisat Patel sir, and Dr. Chintan Kansara sir as a chairperson. The speaker will be invited by the chairperson.
Dr. Parag Shah is a very senior endocrinologist from the city of Ahmedabad. Everybody knows him very well. Thank you, sir, for joining us.
I will invite Dr. Rao, who has done DM from PGI Chandigarh. He is a clinical director of Institute of Gastroenterology, KIMS Icon Hospital, Visakhapatnam. He has authored more than 50 publications in peer-reviewed journals. So we will invite him for the very interesting topic of long-term complications of acute pancreatitis, endocrine as well as exocrine aspects and the surgical aspects.
Thank you, sir, for the kind introduction, and I thank Dr. Yogesh and his team for this opportunity, and it's a wonderful conference, a lot of opportunity to learn. So, setting the ball rolling in the field of pancreatitis, and thanks for accommodating me in time, and I thank the speakers also. So my topic is acute pancreatitis. What are the long-term complications? We often are more interested in the infection, necrosis, vascular complications, organ failure, etc. But what happens in long term after the patient's recovery after all these complications? So nothing to disclose. So after acute pancreatitis, patients can have exocrine and endocrine insufficiency. What is the prevalence? What are the predictors for this insufficiency and how to diagnose them, and what is the general line of management in this population? So coming to exocrine insufficiency, we know that pancreatic secretions are rich in enzymes. Up to 1.5 liters every day it is secreted. Basically, when the acid chyme enters into the duodenum, it releases secretin after stimulating the S cells in the duodenum, and the fatty protein also actually releases the cholecystokinin after stimulation of the I cells in the duodenum. They reach the bloodstream. Secretin actually stimulates the ductal cells to release the bicarbonate and the enzymes from the SNR cells when it is stimulated by the CCK. Also, vagal stimulation causes release of pancreatic enzymes from the SNR cells. So, if you take in broad sense, the most important is the secretin and the CCK. As said, so bicarbonate secretion is after stimulation of the ductal cells by the secretin, and enzymatic secretion from the from the SNR cells after stimulation from the CCK. So patients become symptomatic only after less than 10% of the exocrine pancreatic function is remaining. So 90%. So there is a lot of reserve for any patient. So exocrine insufficiency traditionally is seen, and we hear a lot in chronic pancreatitis. It is because of the ductal obstruction and fibrosis and stricture formation. But in acute pancreatitis, there is a lot of pancreatic necrosis and peripancreatic fat necrosis. There is loss of SNR cells, and that is the main pathogenic mechanism. So there is patchy necrosis of many different cell types in the pancreatic parenchyma. It is exacerbated by the inflammation with disruption of the normal microscopic architecture and the complex and coordinated machinery of secretions. So why fat digestion is affected first? Because there is early impairment of the pancreatic lipase synthesis and secretion, and also there is increased proteolytic degradation of this pancreatic lipase, and there is low bicarbonate output because of pancreatitis, and the duodenal environment milieu becomes acidic, and there is more rapid and complete inactivation of the lipase, which allows precipitation of the glycine conjugated bile acids and further deterioration of the fat digestion. And actually some of the lipase is also secreted from the stomach and other extra pancreatic sources, but usually that is unable to compensate for this loss of pancreatic lipase activity. So there are many ways to actually detect the exocrine insufficiency. So we can do a 72-hour fecal fat estimation or a fecal elastase, which is more commonly available. Alcohol actually etiology has higher risk of exocrine insufficiency than biliary etiology. Patients who have necrotizing pancreatitis has higher risk because they have necrosis of the SNR cells and loss of pancreatic parenchyma, and also severe pancreatitis has higher risk of pancreatic exocrine insufficiency. So if you see the time trends, patients across all pancreatitis, whether it is severe or mild, at admission almost 62% has some kind of exocrine insufficiency, and over a period of time, once the patient recovers and once the pancreatic parenchyma gets normalized or it regenerates, then actually when the pancreatitis settles down, then it comes down again. The exocrine insufficiency improves up to 35% remains in severe cases, 17% in mild cases, and next 5 years actually again there will be some exocrine insufficiency in this population because of the further loss of pancreatic parenchyma or fibrosis like that. So on follow-up, almost 1/3 of patients they have persistent exocrine insufficiency. So what are the symptoms? Patients typically present with abdominal pain, cramps, flatulence, bloating, weight loss, steatorrhea, and weight loss is actually a very important symptom for underlying exocrine insufficiency. Patients can have diarrhea or there can be a deficiency of fat-soluble vitamins. So there are many tests to detect exocrine insufficiency, direct and indirect. I am not going into details. Traditionally, we use long time back this drilling tube was used, but nowadays more practically we actually use the fecal elastase. It is a single stool sample is estimated, and any value less than 200 is actually taken as pancreatic exocrine insufficiency, and less than 100 is actually severe pancreatic exocrine insufficiency. But it has poor sensitivity in milder cases, and when the patient had watery stools and other small bowel diseases like celiac disease, it loses its sensitivity and specificity. So secretin MRCP is also used, but it's not widely available, and you assess other nutritional parameters. So how do you treat? Usually it is by lifestyle modifications. You stop the alcohol, smoking, avoid fatty food. You supplement with a lot of vitamins, especially A, D, E, K, and sometimes B complex also. So pancreatic enzyme replacement therapy, that is PERT, it is the main goal. We should ensure optimum amounts of lipase actually is delivered into the duodenum with along with the food. And actually current preparations, the azoturia, that is the protein loss, can be eliminated, but fat loss, that is the steatorrhea, can only be reduced, but some amount of fat loss or into the stool is it still remains. So the key points during administration are deliver high doses of enzymes, use enteric-coated preparations, and use also acid suppression, especially proton pump inhibitors. Administer along with the food, and the dose based on the content of lipase units, and the dose is usually weight-based or symptom-based, and also what is the stool fat content. So if patient is having 3 meals per day and 2 to 3 snacks per day, then supplement all these enzymes with the major meals, and half the dose if the patient is taking a snack. Usually go with between a dose of 500 to 2500 kg per meal, and higher doses are actually detrimental, and patients are reported to have colonic fibrosis and strictures. So adverse events, patients can usually complain of abdominal pain and cramping and headache after these enzyme preparations. So coming to endocrine insufficiency, so it is pancreatogenic diabetes. It is different from type 2 diabetes. It is now called type 3C, as you all know. So out of all diabetes, around 2 to 9% of diabetes are actually related to pancreatogenic diabetes, and initially 90% are actually misdiagnosed as type 2 diabetes originally, and there is always an overlap. Some patients already having a diabetes can develop acute pancreatitis. So because acute pancreatitis is more commoner than chronic pancreatitis, in population studies it is shown that acute pancreatitis is the leading cause for pancreatogenic diabetes, and 23% of acute pancreatitis, as per the recent meta-analysis, showed that they can develop diabetes in next 3 to 5 years, and almost 1/3 of patients have combined exocrine and endocrine insufficiency in this population of acute pancreatitis. So there is a triad of diagnostic criteria that are proposed but not widely accepted or validated. Patients should have abnormal pancreatic imaging. There can be exocrine insufficiency, and there is absence of islet cell autoantibodies, which differentiates it from other forms of diabetes. So hyperglycemia, actually we know that in any patient with acute pancreatitis, patient's sugar shoot up like 280, 230 in first day, second day and third day of pancreatitis. Usually it was previously considered as a mere transient phenomenon because of stress hyperglycemia. And there is dysregulated glucose metabolism, and it is common in acute pancreatitis, but there is a reversible component also. But certain amount of patients actually do progress and develop diabetes. So the predictors again are the same, like patients who have severe pancreatitis, necrotizing pancreatitis, can have loss of this islet cell volume also, and then can develop diabetes, and there is can be associated exocrine insufficiency, and patients with non-biliary etiology have higher risk of developing endocrine insufficiency. So coming to the pathogenesis, there is acute pancreatitis, and then patient have developed loss of islet cell mass along with the SNR cell mass, and this reduces the insulin secretion and reduces the islet cell hormone response. There can be disrupted insulin and incretin axis, which reduces the incretin hormone response. There can be autoimmune destruction of the beta cells, and that can reduce the insulin secretion. And patients also have, some patients also have pre-existing diabetes and other shared risk factors because of obesity and hypertriglyceridemia or hyperlipidemia. They can also contribute to further worsening of diabetes, and there can be local inflammation and systemic inflammation which increases the insulin resistance, which can contribute to diabetes. So having known the pathogenesis, how to screen them, how to diagnose them, there is no actual protocol when to screen them, but usually in 1 year you have to be careful, like diagnosing them with fasting sugar or HbA1c like that, and every 6 months or so in the initial 1 year to diagnose these patients. So there is one marker which is which has been shown that to predict to differentiate between the regular type 2 diabetes and acute pancreatitis associated type 3C diabetes mellitus, which is actually oxyntomodulin. It is a gut GLP-1 molecule, and its levels are reduced, this oxyntomodulin levels are reduced in acute pancreatitis related diabetes mellitus. That's how we can differentiate between type 2 diabetes and type 3C diabetes related to pancreatitis. So again, the risk of diabetes worsens as the time progresses and on long-term follow-up. So first 5 years, the risk of diabetes, as per meta-analysis published some 10 years back, it showed around 1/3 of this population can have diabetes, but the risk of diabetes jumps to more than 40 to 50%, like it becomes 58% once they cross 5 years of follow-up. So what is the importance? You have to differentiate between these two things, the type 2 diabetes and type 3C diabetes. If you see type 3C diabetes, actually it involves chronic pancreatitis, pancreatic cancers as well as acute pancreatitis. So half of the diabetes actually secondary to pancreatic cancers, in fact, occur within 2 to 3 years before the diagnosis of pancreatic cancer. And as such, type 2 diabetes has higher risk of pancreatic cancers. But if you see acute pancreatitis related diabetes, it has worse glycemic control and higher complications, especially the non-vascular ones, and they have more brittle diabetes, difficult to control diabetes. Almost 30% has hypoglycemia, and type 3C diabetes has higher non-vascular complications, especially the infections, COPD, renal disease, gout, mental disorders, pancreatic cancers, and also colon cancers. And they have 13% higher all-cause mortality compared to the general population. So it's also important because the HbA1c levels are higher at 1 year and 5 year and as well as at diagnosis in type 3C diabetes compared to type 2 diabetes, and also the requirement for insulin is higher in patients with type 3C diabetes compared to type 2 diabetes. So that has very important therapeutic implication, and the risk of poor glycemic control is up to 30% at 1 year and almost 70% till 5 years. So it's very difficult to control these patients even on higher doses of insulin, and they require higher doses of insulin. So how do you treat? Treat the basic acute pancreatitis first, because if you reduce the severity of pancreatitis by giving IV fluids, aggressive hydration, then some amount of severity can come down. Treat the necrosis component. And also when you actually control the sugars, you follow the same principles as in type 2 diabetes, and also treat the shared risk factors, especially the obesity and hyperlipidemias. And remember that some studies have shown that if you use insulin liberally, it can actually progress worsen the acute pancreatitis. And remember that these newer agents, the DPP4 inhibitors and GLP-1 agonists, actually has the risk of pancreatitis, so please do avoid them. So what is the life after long-term complications of acute pancreatitis? We can still see exocrine endocrine insufficiency can happen after acute pancreatitis. More risk is involved if there is severe pancreatitis and necrotizing pancreatitis, especially in alcohol-related pancreatitis. 2/3 have exocrine insufficiency at the time of discharge, and 1/3 still this exocrine insufficiency can persist. Use pancreatic enzyme replacement therapy, supplement with ADEK, vitamins, and also diet modifications. Coming to endocrine insufficiency, around 23% develop in next 3 to 5 years, and beyond 5 years it's almost 58%. Use metformin and insulin usually, and avoid GLP-1 agonists and DPP-4 inhibitors. Thank you so much for your patient listening.
So talk about endocrine and exocrine complications following acute pancreatitis. As an endocrinologist, I would just like to have your opinion. You talk about severe necrotizing has a more chance of endocrine insufficiency. Is there any study or the observation about the level of amylase lipase, duration of acute pancreatitis, and the site of acute pancreatitis? Any correlation with developmental pancreatic diabetes? Number one. Number two, what is the reason thought of after 3 years there is more chance of having the diabetes, whether it's a poor beta cell mass, and then on top of that there are more risk factors of type 2 diabetes, or more of a autoimmunity is triggered by the pancreatitis and leading to the more chance after 3 years.
Right.
Because the acute phase is already over.
Right. So regarding the first question about the location, studies have shown that there is no correlation with the location, head, body, and tail. So we do know that the islet cell mass is preferentially located in the tail, but still in the amount of necrosis in versus head, body, and tail, there is no difference. Number one. Number two, regarding the reason why it still progresses, probably, I mean, it's not well studied. That there's only the meta-analysis have shown about the time trends, but there is no actual investigation into the causative role why it has progressed. So probably there is an event like sentinel acute pancreatitis event. So these people actually progress over a period of few years. If the single event is so severe, then even the etiological factor is still taken care of. These patients can still progress. So there can be a still ongoing loss of pancreatic parenchyma, and they can progress into chronic pancreatitis. And as the age progresses, probably they may acquire more risk factors for type 2 diabetes, and at that time it might be very difficult to differentiate between whether it's type 2 or type 3C.
More questions from the house? Yeah, please. Sir.
Mike, please.
As you rightly said, sir, that initial diagnosis of diabetes, be it type 2 or type 3C, message should be passed that the initial imaging in form of at least ultrasonography should be done, even if there is no pain, even if there is no complaints. So initial weight loss, you consider it be a diabetic weight loss, but maybe underlying malignancy would be the case.
True.
So that message should be passed on very clearly.
Yes, yes. If there is unusual weight loss and
Hello.
Yeah.
Yes, Dr. Joshi from Kadi, General Surgeon. What is the ideal time to intervene for surgery in case of acute pancreatitis complications, like necrotizing pancreatitis or another condition like peritonitis happens? Which is the ideal time as per physician opinion?
Sir, we have already that same session. We will answer that in next.
Okay. Thank you, sir. Thank you.
With positive time, we are not taking any more questions. Thank you, sir. Thank you very much.
Thank you.
Thank you, sir. Thank you, chairpersons. Next topic is management of acute pancreatitis. For that, I would like to invite Dr. J.K. Anand, sir, Dr. Jignesh Patel, sir, Dr. Saumin Shah, sir, Dr. Manish Agrawal, sir, and Dr. Dhanashri Lapakari now. The speakers will be invited by the chairpersons.
So, we have a management of acute pancreatitis. It is very beautifully divided into golden hours, then weeks, and 4 weeks bonds. So for the first lectures, I will invite Dr. Sukrit Sood. He is from Vedanta, New Delhi. He will touch upon the first golden hours, which is also a new concept in management of acute pancreatitis. So over to.
Thank you, sir, for the kind invitation. At the outset, I'd like to thank Dr. Yogesh for all the effort he has put behind this and to invite me. So I'll be dealing with what sir rightly said is the golden hours or the golden 2 days for managing acute pancreatitis irrespective of etiology, the first 48 hours. So we all know that acute pancreatitis is one of the commonest GI emergencies that we see in our daily practice. In even our practice, we see upwards of 20% of our total emergencies from the emergency department to be acute pancreatitis of varying severity. So the instance in the world is upwards of 30 per lakh per year. Mortality can be up to 5%. Two distinct phases we all know. The first is the first 7 days, which will be divided into 2 parts between me and Dr. Rai, where the inflammatory response syndrome, the cytokine storm without organ failure is the main problem. And after a week, the sepsis and local complications like collections take over as the problem. So we first have to triage all our patients that we see in the outpatient department and the emergency into mild, moderate and severe acute pancreatitis as per the Atlanta criteria. The moderately severe would have some local complications, pancreatic or extrapancreatic, and a transient organ failure, which resolves within the first 2 days. Whereas severe acute pancreatitis would be the ones where organ failure persists beyond the first 48 hours, and organ failure would be defined by the modified Marshall criteria, which I am not discussing here. So whenever a patient comes to the emergency department, we run a virtual triage where we first make a positive diagnosis, where we take 2 out of 3 features, the classical abdominal boring type of pain radiating to the back, their lipase or amylase more than 2 times upper limit of normal, an ultrasound showing beyond doubt that there's pancreatic inflammation or bulky pancreas, which is more often the radiologists try to get away with saying the bowel gases. So then we start workup, then we first determine the severity, we run a modified Marshall score, we determine any extrapancreatic problems, any organ failure, the sensorium, any respiratory disorder, the acute kidney injury, and the severity of pain, and we try to determine where to admit them. So we, as per the severity, we determine whether they'll go to the ICU for further care or they'll remain in our HDU or in the ward. Then comes the ecological workup, which I'll be coming to later. So what are the problems our patient faces? When we see them in the emergency, first thing is they have to be relieved of the symptoms to at least a large degree, so they are in severe pain. So coming to the analgesia, the options as per the pain ladder we know are NSAIDs and opiates. Concerns always with the safety, we don't want to give opiates to all our patients. NSAIDs in elderly patients are two sides of the coin, so we can end up with acute kidney injury or making it worse, and there can be GI bleeds in patients who may have already been on antiplatelet medications. Opiates on the other hand can worsen ileus, which already exists in upwards of 50% of our patients of acute pancreatitis, and there can be respiratory depression, which can also not only make an underlying acute lung injury worse, but also make our perception of the acute lung injury much more difficult to gauge. So our randomized controlled trial way back in 1985 suggested the rectal indomethacin, which we now commonly use in our ERCPs, have provided good pain relief without side effects, but in our practice we do not use this. And NSAIDs can prevent post-ARC pancreatitis without obvious evidence of harm in that study. And opioids are a way of effective pain relief as well. The AIMS group had recently published their experience with pentazocine in significant pain, and their control of pain was better than diclofenac in acute pancreatitis. In our practice, in the patients who are writhing in pain and nothing else is working, we do use patient-controlled analgesia with fentanyl as a rescue agent. Then the most important part of, I think, making a difference in the 48 hours is fluid resuscitation. The concepts of fluid resuscitation have almost taken a U-turn in the last decade or so. Earlier we used to determine how much is the fluid loss. The study from 1974 helped explain that in 48 hours, a fluid loss around 3.5 liters is expected in mild to moderate cases, with upwards of 5 liters occurs in severe acute pancreatitis. Dave Madaria et al., who has gained a lot of fame this year with his waterfall study, earlier in its 2014 study had also estimated a median fluid loss upwards of 3 liters, and the predictors of poor prognosis and higher fluid loss were younger patients, alcoholics, patients with deranged blood glucose in the first 24 hours, and significant features of cytokine storm and SIRS. Now, how aggressive should our fluid management be? There are a lot of studies which earlier favored aggressive therapy, but now, as I said, we are taking a U-turn. So this is a study from 2013 where they divided the groups into an aggressive group where they give 4.5 liters in the first 24 hours, and a moderate or non-aggressive group we gave up to 3.5 liters. And they used up to 20 ml per kg bolus and then maintained at 1.5 to 3 ml per kg per hour depending on their fluid status. Now, how did they find out the effect of fluid therapy? In the same study, they used hemoconcentration as a marker which determined the hematocrit, and rising hematocrit in the first 24 hours was correlating with greater necrosis and poor prognosis, and giving less fluid on the other hand also led to organ failure and greater mortality. Our recent studies, like the waterfall trial I'll be coming to later, has also pointed out that aggressive fluid resuscitation doesn't seem to be working as well because the organ failure rates, acute fluid collection rates in the first 2 weeks, need for longer ICU care, morbidity and mortality all seem to be increasing in this subset. Now, how do we decide which fluid? There's been an age-old debate between saline, normal saline and ringa lactate. So there was RCT in 2011 by Wu et al. Where they took 40 patients and showed ringa lactate was better than normal saline, and normal saline patients, a minority in the study, had hypochloremic acidosis. But even in our study, in our practice, we do use normal saline still, but we keep an eye on their blood gases as well at the same time and the bicarb levels. Now, fluid therapy, the goals have to be determined from the beginning. It can't be based just on writing bolus injections and ml per kg per hour infusions. So we have to keep monitoring our patients, especially the moderately severe to severe group who are in the ICU or the HDU. They maintain a mean arterial blood pressure at least 70 millimeters of mercury, hematocrit around 40, and urine output upwards of 0.5 ml per minute. And we want to monitor both non-invasively, what we use more commonly in the ICU, we use the IVC diameter. If it's less than 1.5 centimeters or we have a variability index of more than 50%, there is still capacity to give more fluid and the patient is still in relative deficit. And lung ultrasounds are also done to make sure they don't go into fluid overload. Invasive monitoring is done in very sick patients where central lines are placed, but it still does not give very good feedback when the patient is on a ventilator. On the other hand, arterial pressure waveform and stroke volumes are much more reliable. Now, the recommendations currently, we know there are a lot of variability across practice guidelines. A reasonable amount of fluid in the first 24 hours should be around 3.5 liters, and depending on the fluid assessment and the severity of acute pancreatitis has to be tailored as per your patient. Patients who are high risk for going into overload are obviously the elderly, patients who are cardiac or pulmonary comorbidities, patients who are going into abdominal compartment syndrome and abdominal hypertension, which has to be gauged as well with a catheter in the urinary bladder with a pressure gauge, and those who have renal failure. And then beyond 48 hours, you have to go by their urine output. So these are the two American guidelines we all like to quote before the waterfall study, but even there was not much true data coming out from these. That's why the need for an RCT was there. So in 2013, the ACG guidelines had stressed upon up to 500 cc per hour of ringa lactate was given on day 1, and the goal was to bring down the blood urea nitrogen levels. They did not use hematocrit as the criteria. In 2018, the AGS guidelines did not give a clear answer. They went completely goal directed from the first minute and recommended against using hetastarch. Now, this is the study which in the last year has gained a lot of goodwill from the Gastro community because it made our job much easier. So this was done by Demetaria's group, and it compared aggressive or moderate fluid resuscitation in these patients. It's also called the waterfall trial. So there were 250 odd patients from 18 centers divided into two groups. First one was given the aggressive fluid resuscitation, that is starting with a bolus of 20 ml per kg and then switching to an infusion of 3 ml per kg per hour. And the moderate group was given a bolus of half that, and in case of hypovolemia only, or those which did not have hypovolemia at the first assessment did not get a bolus, and they were given just an infusion of 1.5 ml per kg per hour. And the assessment was done at 12 hour, 24 hour, 48 hour and 72 hour points, and the fluid resuscitation from there on was as per their clinical status. The primary outcome of the study was determined to be development of moderate or severe pancreatitis during the hospitalization, and the safety outcome was percentage of patients ending up with fluid overload. So they concluded that giving an early aggressive fluid resuscitation, this group had higher instance of overload without improvement in clinical outcomes or mortality. So this is what we now stick to. This flow chart would be the most important part of the first 48 hours. So always determine hypovolemia first of all. So any of these criteria should, only one criterion should be present. A serum creatinine at baseline above 1.1 or BUN above 20, that is urea above 43, hematocrit above 45%, increase in the creatinine or BUN or urea above the previous value by at least 0.3, urine output falling below 0.7 ml per kg per hour, and a systolic BP below 90 without any other explanation for hypovolemia, and symptoms of dehydration determining the mucosal nature of oral mucosa and the skin turgor. And preferred solution is activated ringer, and additionally potassium at 4 milliequivalent per liter in the fluid and 40 milliequivalent per day has to be administered. And they also define fluid overload for these criteria with non-invasive markers of heart failure on X-ray, X-ray features of pulmonary congestion, invasive catheterization ICU patients determine a pulmonary wedge pressure or left ventricular end-diastolic pressure above 18 and right arterial pressure above 12 and the cardiac index less than 2.2 liters per minute per meter square. And the second criteria to be clinical feature of heart failure like dyspnea, and the third any one sign like peripheral pedal edema, chest having rails, and increased JVP. So how do they start? As I said, now we have switched to moderate fluid resuscitation. So start, those who are hypovolemic, give this bolus of 10 ml per kg, switch them over all the patients to 1.5 kg per hour if they are euvolemic, and then whenever you keep checking at these time points, and also they added the oral feeding can be started. This will be dealt with in more detail by Dr. Rai. So when the patient is normovolemic, you give an infusion of 1.5 kg per hour and then keep checking as per these points. And if they remain hypovolemic, keep repeating a bolus till they become normovolemic. And if the BP, the systolic remain less than 90 or urine output does not pick up over 0.5, then you continue your infusion till you make them euvolemic. So there is a major issue with prophylactic antibiotics. Most of the patients who end up in our emergency truly are beyond 48 hours and they have been exposed to all sorts of antibiotics without a true need. Now a lot of RCTs have shown no real benefit, and actually we end up having multi-drug resistant bugs in the second week and onwards in these patients. We are doing a study currently to prove this. When a meta-analysis with 8 RCTs after the year 2000 showed in 2 groups of 220 each that the antibiotic in the placebo group, there is no benefit seen, and early antibiotics in another study by Kwai et al. From Japan had possible benefit, but only numerical. Though we understand in India, Dr. Talukdar's study from AIG showed that 66% patients in India do end up with prophylactic antibiotics, and the problem we face, as I said, multi-drug resistant infections, more gram-positive infections in our pancreatic collections, and more fungal infections later on. Now we started using procalcitonin where it's available to guide our antibiosis. And this was a study published in the Lancet called the ProCap study. There they used divided the patients into 2 groups. One was Procal guided antibiosis, one was physician guided. The antibiotic prescription was much lower in the Procal guided group, and they concluded that this Procal guided care can reduce your injudicious use of antibiotics without an increase in risk of sepsis or harm. So nutrition, we should understand we can start nutrition early. Putting everyone nil per oral is never the answer for any disease possibly unless there's a perforation suspected or you're not clear about the diagnosis. So in mild acute pancreatitis, severe acute pancreatitis, does the timing affect the disease course? We should stick to enteral nutrition, how to give it, whether we want to give it orally, via nasogastric tube or nasovaginal tube, and what are the target calories. So as per the guidelines, we know that oral feeding in mild cases can be started once the patient feels better, the pain has started to decrease. You want to step up gradually from a clear liquid to a full liquid diet, just a couple of minutes more. So an enteral tube feeding would be the primary therapy in most patients. Do not switch to TPN too early, and enteral does much better in decreasing infections, organ failure and mortality. Start within first 72 hours, if not first 24 hours, it has showed similar benefit. But always stick to enteral nutrition unless no other option. And NG and NJ routes was similar in terms of acceptance, as well as no difference was there. But in real life scenario, patients do not tolerate NG feeds all the time and have to be switched to NJ. And how much to feed? We want to give polymeric feeds around 30 calories per kg with 1.2 to 2 grams of protein per kg. And we want to rarely rely on TPN, especially in the first 48 hours. Coming to ERCP, everyone with a stone in the duct with acute pancreatitis should not get ERCP. That is a very highly contentious issue currently. So patient who have acute pancreatitis with acute cholangitis, rising LFTs, patient sick, and ERCP within 24 hours can change the entire outlook of the patient and can bring your patient out of the ICU within 24 hours as well. If there is a high suspicion of CBD as determined by gradual worsening of LFTs, you can do an MRCP or ultrasound first and then do an ERCP in a semi-urgent manner. Even this is contentious whether the 72-hour guideline has not shown any mortality benefit in studies. And whenever you do an ERCP, take extra precautions, give adequate IV fluids, put a PD stand, and even a wire enters the PD, and give rectal endomethacin in all cases, and guide wire cannulation is preferred over contrast injections. So my take-home messages from the talk would be the first few days are the golden window, extremely critical for survival. Optimum hydration, not overhydration. Analgesia, you choose whether NSAIDs or opioids as per the patient's pain requirement. Early anti-nutrition is important. Do not give antibiotics haphazardly and subject only very limited selected patients to ERCP and not all those with the stone in situ. Thank you everyone for the kind hearing.
Combined question with the last. So I will invite the second speaker. He is Dr. Praveen Rai. As you all know, he is from SGPGI Lucknow, and he will give talk 48 to 1 week in a management of acute pancreatitis.
Very good afternoon. I'd like to thank Dr. Yogesh for this wonderful opportunity. I'll be talking about management of acute pancreatitis 48 hours to 1 week. So as you know, there's a recent increase in the incidence of acute pancreatitis, and what one needs to recognize that there are two distinct phases of acute pancreatitis, less than 1 week and more than 1 week. Why this is important? Because less than 1 week, it's basically systemic inflammatory response syndrome and or organ failure, while more than 1 week is characterized by local complication. What we are focusing here is predominantly less than 1 week in this particular lecture. And there are two peaks of mortality that one needs to know, and half of these occur during the first 2 weeks. So very, very important phase. So if you see, these are all the aspects of management in the first week, and the four of these have been covered. These are the ones that I would like to touch upon. So this timeline is very, very important. So why this is important? Because it tells you what is happening exactly after 48 hours and up to 1 week. So we determine whether the patient has got sterile or infected necrosis, or there is a suspicion of infected necrosis. We have persistent organ failure, which again is defined by organ failure persisting for more than 48 hours. Then we predominantly have the nutrition, which has been touched upon. Then the need of CT scan is after 48 to 72 hours, and antibiotics, if required, starts during this phase. So if you see a 35 male with a recent alcohol intake, no history of gallstones or acute pancreatitis, presents with a epigastric abdominal pain radiating to the back with fever. Serum lipase is 800. So predominantly in this particular case, what imaging is needed to require to make a diagnosis? So if you see this, the diagnosis of acute pancreatitis predominantly requires abdominal pain, serum lipase and amylase more than 3 times the upper limit of the normal, and characteristic finding on abdominal imaging. Amylase, however, can be normal in alcohol-induced pancreatitis, and amylase is high in absence of acute pancreatitis and macroamylasemia. So when should a CT scan or MRI be done? So this aspect I'm intentionally touching because sometimes it's very, very important to try to position your investigation at an appropriate time. So CT scan may be done on admission when there's a diagnostic uncertainty only. Within the first week from the onset, that is after 72 hours, when there is a failure to respond to conservative management, that's the time you can do a CT scan. And from 2 to 4 weeks, when you're trying to evaluate the complications of CT scan, complications of acute pancreatitis. And after 4th week, primarily to plan further management and monitor the treatment response. So MRI, there are certain distinct advantages: detect CVD stones, pancreatic duct disruption, contrast allergy if the patient has, you can do an MRI. So in this particular case that I have discussed, you don't need any imaging to make a diagnosis. You already have a diagnosis of patients of acute pancreatitis with these two parameters alone. So unnecessarily you should not be doing an imaging, especially a CT scan. Again, this has been touched upon, the etiological workup you need to do. So coming to the point of day 2 to day 4, this particular patient say develops fever 102, TLC 16,000, creatinine of 2.8, bilirubin of 0.9, SGPT 78, blood urine culture sterile, and ultrasound shows a small collections. So the main concerns during this period, that is after 48 hours, are: one is organ failure, the another is diagnosis and treatment of infected necrosis. So mind you, this infected necrosis usually occurs after 1 week, but nothing stops it from happening early in the course of the disease, maybe at day 3, day 4. So you have to keep a vigil whether the patient shows any features of infected pancreatic necrosis, and the nutrition. So the organ failure, how do you predict about organ failure? This is predominantly by the presence of persistent systemic inflammatory response syndrome, which is defined by pulse greater than 90, respiratory rate greater than 20, temperature greater than 38, and WBC greater than 12,000 or less than 4,000. So if you have any of these two, they suggest a persistent SIRS and may indicate the presence of organ failure. So the organ failure, how it is defined? Basically respiratory, renal, cardiovascular status, and a point of more than 2 indicates organ failure. So it's very, very important. So why this is important? Because these patients need to be managed only in ICU, and persistent organ failure more than 48 hours again carries a high mortality to the tune of around 30 to 40%. It's very, very important to know. And once the patient is being managed in a center where ICU facility is not available, patient should be referred appropriately to centers of expertise. And prognosis, organ failure is a key determinant of survival, mortality 30 to 40%. And what you need to know is timing of organ failure again is important. Early or late organ failure. So this study from AIMS, this just tells you that you have an early onset primary organ failure that indicates, which is because of systemic inflammatory response syndrome. The mortality is to the tune of around 43%. However, late primary organ failure, the mortality again is high. Vis-a-vis infected pancreatic necrosis without a primary organ failure again carries a significant mortality to the tune of around 36%, while if there is no infected necrosis, there is usually no mortality. So you need to distinguish between a primary organ failure and a secondary organ failure, which is usually because of infected pancreatic necrosis. So organ failure, do you have any specific treatment? This is a Cochrane review which suggests that whatever the treatment modalities you use, there is no difference in the outcome based on this Cochrane review. So infected pancreatic necrosis, as I mentioned, carries a very high mortality to the tune of 30%. Diagnosis of infected pancreatic necrosis becomes very, very important because you want to treat it timely, very, very important. And if you see this chart, necrotizing pancreatitis plus clinical deterioration, you have fever, persistent unwellness, bacteremia or worsening leukocytosis. This usually happens after 1 week, but can happen in 3rd and 4th week, and you have to be cautious about it. CT scan should only be done after 72 hours because otherwise it will not show the total extent of necrosis. If you have necrotic collection with gas, it indicates to the tune of 97% that the patient has got infected pancreatic necrosis. So very, very important, the presence of gas. If the patient has that, you start with treatment and the empirical antibiotics. The antibiotics, so here it's not empirical, it's against infected pancreatic necrosis. It's carbapenems, quinolones, metronidazole or 3rd generation cephalosporins. And if you have a necrotic collection without gas, one can resort to doing a CT-guided FNA, though in clinical practice it's rarely needed. And the reason why it is not usually required is that it's got a false negative to the tune of around 12 to 25%. And usually it's unnecessary, and there is a theoretical risk of contaminating a sterile collection. However, in scenario where one is already using an antibiotic and the patient is not responding or is deteriorating, this may give you an organism and tailor antibiotics accordingly. So this chart has been shown by the prior speaker. So this point is very, very important. So you do a procal value in the patients with acute pancreatitis, and if this value is more than 1 nanogram per ml, you can consider starting antibiotics. This is still not figuring in the guidelines because of the recent study, 2022, but I think a very good paper which tells you a marker by which you can choose to give antibiotics in patients. So procal, doing a procal and serial procal values helps you to treat the patient in a correct way. So coming to nutrition, when to start feed, what route, nasogastric or the nasojejunal. So traditionally it's nil per oral. Why? Because the bowel rest in an attempt to avoid further stimulation of pancreas. However, now there is a clear evidence that the early feeding helps. Why? Because it protects gut mucosal barrier, reduces bacterial translocation, reduced risk of infected pancreatic necrosis and serious adverse events. Again, this is a study which shows if you feed early, there's a decreased risk of intervention for necrosis, trends for higher rates of infected pancreatic necrosis, multiple organ failure risk decreases. However, there is no difference in mortality. So based on this, the AGS recommends initiation of early oral feed that is within 24 hours instead of keeping the patient nil orally. However, there are patients who may be having pain, vomiting or ileus. Feeding may need to be delayed beyond 24 hours in this. So again, in patients with acute pancreatitis and inability to feed, the AGS recommends enteral rather than the parenteral nutrition, 12 RCTs, which show that if you are feeding enterally, it is an advantage, decreased risk of infected pancreatic necrosis, decreased risk of organ failure. So very, very important to give enteral rather than parenteral. NG or NJ, again, there is no difference. 3 randomized controlled trials show there is no difference. However, certain points which are very important to remember is that compared with nasojejunal, nasogastric is easy to place, more convenient and cheaper. However, the problem is there is a risk of aspiration which may preclude practitioners from using NJ. And about 15% of patients have digestive intolerance because of delayed gastric emptying, outlet obstruction, and in this situation, nasojejunal tubing may be required. So very, very important to decide accordingly. So what type of diet? Traditionally it's a clear liquid diet, but now with current evidence you can give a low fat, soft diet. Some guidelines recommend even a normal fat, soft diet. Standard polymeric diet, and again a meta-analysis which shows that there is no evidence to support a specific enteric formula. So when should the parenteral route be given? So in conditions like bowel obstruction, abdominal compartment syndrome, prolonged paralytic ileus and mesenteric ischemia, parenteral nutrition may still have a role in these situations. So again, the role of surgery, it's very, very important to remember that if you're dealing with mild acute pancreatitis, the patient should undergo surgery in the same admission. Why? Because it reduces the need of readmission, that is 18% readmission within 90 days if surgery is not offered during the same admission. So very, very important to remember this holds for mild acute pancreatitis. So to summarize, a cross-sectional imaging early acute pancreatitis is not associated with improved outcomes. CT, if required, is performed after 72 hours. No role of prophylactic antibiotics in early acute pancreatitis. Early onset primary organ failure has a high mortality. Infected pancreatic necrosis should be detected early and treated timely. Enteral nutrition in severe acute pancreatitis has reduced mortality, systemic infection, multi-organ failure. Cholecystectomy in the same admission in mild biliary pancreatitis. Thank you.
Jahangir sir is there? Yeah. So he is the Dr. Jahangir Basa. He is a gastroenterologist and excellent, he has done excellent work in the pancreas. He is from the Asian Institute of Gastroenterology, Hyderabad, and he is going to discuss the management of pancreatitis between 1 to 4 weeks. Sir, over to you.
Thank you, Dr. Yogesh, for the opportunity, and thank you, chairpersons. So I'll be mainly discussing acute pancreatitis management between 1 and 4 weeks. Dr. Yogesh has put a very strict timeline for the management and how to discuss. So we had discussed previous 2 talks, but they are mainly related to the early management. So I would be discussing 1 to 4 weeks. So before going into the topic, we need to understand what exactly the natural history of acute pancreatitis. So if you have listened to the previous 2 speakers, it is divided into early phase and late phase. So first 1 week is early phase. We heard already SIRS or organ failure dominates the course, and the line of management also we had discussed. But beyond 1 week, this is the late phase, and here the main problem is the local complications, especially the infected necrosis, and the drainage modalities of these infected necrosis is the main aspect of this particular topic. But if you look at beyond 1 week means it can be more than 4 weeks also. I would be specifically restricted to 1 to 4 weeks because some overlap things would occur or happen between this time period. So before going into what happens, so if you see the acute pancreatitis, in majority it is mild cases, in about 20% it is moderate or severe. So beyond 1 week, whatever the complications or issues that we are going to discuss happens in this particular group, that is moderate or severe group. Very few patients with mild pancreatitis with the fluid collections can have complications after 1 week, but most of them would resolve. So that means the topic specifically restricted to the pancreatic necrosis or the necrotizing pancreatitis with fluid collections. So what are the critical issues in this particular frame? So one thing is imaging that already we discussed in the previous talk, that is important. The second thing is organ failure and the nutrition optimization. We should continue when there is a persistent organ failure, and nutrition optimization continues throughout the whole course of management. And the most important thing that we would address here is infected pancreatic necrosis. So imaging, we know that CT scan is important. Pancreatic protocol, ideal time is 5 to 7 days. There is a severity index where a score of 0 to 10 has been given. 10 means more severe, and we can use this CT severity to correlate with the severity of the pancreatitis or the outcome of the pancreatitis. If you look at the morphology in these 2 CT scans, in interstitial pancreatitis, you can see the normal enhancement of the pancreatic parenchyma without any necrosis. In necrotizing pancreatitis, you can see there is no enhancement, classifying it as a necrotizing pancreatitis. The next important thing is the fluid collections. According to the revised Atlanta, acute pancreatitis fluid collections made simplified here. So APFC develops in interstitial pancreatitis, acute necrotic collections in acute necrotizing pancreatitis. These collections evolve over 4 weeks with mature wall to develop into pseudocyst and von. So the drainage, sometimes they require if they get infected or become symptomatic. So drainage is easy or can be considered if it is beyond 4 weeks or a mature wall is formed. But before 4 weeks, that is between the 1 to 4 weeks, this is a very strict time period. When the patient becomes symptomatic, drainage has to consider, it would be challenging. So what exactly is the infected pancreatic necrosis here? So as we discussed, there would be necrosis in the pancreatic parenchyma. In about 30% of the patients, there would be infection, and that has a severe mortality where you can see some gas bubble formation, classifying that is a infected pancreatic necrosis. So why is it challenging? So why need to discuss this? I will explain with a particular case scenario. 35-year male with ethanol related. He had organ failure in the first week. He improved with a supportive treatment. He got a CT scan at 1 week. There was acute necrotizing pancreatitis with acute necrotic collection with a CT severity index 10/10. So up to this is okay, but he developed fever on day 10. So this is the common scenario, common challenge, and how to proceed this. So why is it challenging? If you see that there are a number of challenges. The first challenge is what exactly is the cause of fever? Can it be related to SIRS, or it is some other source of infection, or it is an infection in the pancreatic necrosis? So we have to prove before we take any decision. So suppose we proved that this is the infected pancreatic necrosis, antibiotics were decided, but how long to continue the antibiotics? Because they are costly, cost-effective, and there is no optimal time duration, how long to continue, and affordability issues also would come. So this is again a challenging issue. Suppose we started antibiotic, but there is no response to the fever. He is continuously developing fever, and the next option, ideally we all know that he requires a drainage, but the drainage is not feasible because you have seen the previous CT scan, it is not a mature wall. Then how to proceed? So for example, if you proceeded and we did percutaneous drainage, but the fever persistent, then what to do next? And can we subject him for surgery? Because again it is a challenging, because the patient general condition is very poor and the albumin is very low. So again a difficult candidate for surgery, ultimately a very high mortality, and also it is a costly affair to manage this issue. So again I'll bring this flow chart here. If you see the necrosis, in about 60% it is sterile, in about 33% is infected. But the mortality is very high with infected pancreatic necrosis, almost 35%. The same has shown in this PGI study, where around 16% had a mortality with acute necrotic collection. So next thing, I would like to address each individual challenge while discussing the subsequent topic. So when to suspect infection in acute necrotizing pancreatitis? As we heard, sometimes there can be a gas formation, and routinely we don't practice FNA, but if FNA shows a positive gram stain or a culture, again an important parameter. And the most important, commonly we rely on the clinical suspicion of infection, that is high fever, raised WBC, sometimes procalcitonin value, also important. And the most important are the criteria that decides whether we should intervene or not is the persistent or a new onset organ failure. So even without all these evidence, if the patient is having fever and there is a persistent organ failure, that means we are probably dealing with a infected pancreatic necrosis. Coming to the timing of infection, if you see here in this paper, the usual timing happens at around day 14. So exactly at the second week of illness, the infection starts, and we sometimes can be early also. Approach to management, I would discuss initially antibiotics and then drainage. Next important thing is we will have to discuss about the antibiotics, because that is the initial or the first strategy we adapt when there is a suspected infected pancreatic necrosis. If you see the pancreatic penetration efficiency factor, it is very high for imipenem and meropenem, 0.98. The next best penetration is for fluoroquinolone, ciprofloxacin and ofloxacin, and subsequent category would come for the third generation cephalosporins. Again, the antibiotic choice depends upon the culture or the local antibiotic protocol. Majority of patients who require antibiotics ultimately undergo for intervention, but the main aim of antibiotics is to buy time so that the collection becomes mature. And what is important here is when we do intervention in a mature collection, the complications are less and the morbidity and mortality is better. So the main aim of antibiotics is first thing to control the infection, but if infection is not controlled, at least we buy time for the collection to become mature. So there is again another strategy in this RCT where they compare immediate drainage, that means once they diagnosed infection they started intervention, and postponed drainage, and there was no difference in the outcomes in this Dutch pancreatitis group study. There are various options for drainage, surgical, percutaneous or endoscopic drainage, but with this landmark study from NEGM where they compared the open necrosectomy with a minimally invasive strategy. The traditional treatment previously was open surgery for the necrosis, but with this minimally invasive strategy means they first place a percutaneous catheter. After that, if they require necrosectomy, and then video assisted retroperitoneal debridement. What they compared is between these two groups, they have taken 88 patients. The primary endpoint was a composite endpoint, that means either major complication or death, which was significantly high in primary open surgery group when compared to minimal invasive group. And again, the secondary complications like organ failure or the major complications were all severe in the open necrosectomy. This has changed the concept that is minimally invasive strategy is a better option when compared to open necrosectomy. Again, percutaneous catheter drainage, it is the best and the most commonly adopted, especially in this particular frame. So according to AGA guideline, between 2 to 4 weeks, when there is a suspected or confirmed infection without a matured wall, and the patient is not responding to the conservative medical treatment, a percutaneous drainage is can be considered. And we can consider a necrosectomy also if there is no response to the fever. That is, again, we discussed one of the challenge. And if you see in this acute necrotic collection, that means before 4 weeks in this study from the AIMS group, almost 20 were managed conservatively but with antibiotics. That means PCD was required in about 37, and subsequently PCD surgery was also considered, and percutaneous endoscopic necrosectomy also considered. So we adopt a step-up approach. In any strategy we adopt, either surgical or percutaneous or endoscopic adaptation, which has a better outcome. Coming to the endoscopic drainage, we all know that this is a very commonly adopted strategy nowadays, but I would be discussing mainly on this particular paper because this is limited to this particular time frame for my topic specific. So where they compared early versus standard drainage. Early means before 4 weeks, standard means beyond 4 weeks with endoscopic drainage. In early drainage, 76 patients were there. In beyond 4 weeks, 117 patients were there. What they observed is the morbidity. That means the median time of stay in the hospital or ICU was better with the early drainage when compared to the late drainage. But if you look at the mortality was high with the early drainage. So when the intervention is required, you can adopt early drainage, but the accepted more risk. That risk can be sometimes either because of the natural course of the acute pancreatitis because it is severe. And in endoscopy also there is a step-up approach we follow. Initially we just drain and later if required we do necrosectomy. So to take home message from this talk would be understanding the natural history of acute pancreatitis is vital, and in this particular time frame infected pancreatic necrosis complicates the clinical course, and this is a time frame with a high mortality and morbidity. Appropriate timing and modality of intervention plays a critical role. Step-up approach strategy gives a better outcomes. Thank you.
Thank you for the nice and lucid talk. Our last speaker of this session of the dynamic Dr. Mukesh Kalla, and he is from the Sir Kalla Institute from Pink City of the Jaipur. Dr. Mukesh Kalla, he is going to talk how to management of the acute pancreatic after the 4 week to beyond up to the 12 week. Dr. Mukesh Kalla, sir, please.
Thank you, sir. At the outset, I would like to congratulate Yogesh for organizing such a wonderful talk, pursuing everyone to be here. And on behalf of all the delegates also, I would convey heartfelt thanks to Yogesh because he is one person who has, given such a big capsule of information to all of you. And my co-speakers were excellent, and for the particular topic which I am going to speak is about 4th week onwards management of acute pancreatitis. Okay. इसको बड़ा करना है. So management of acute pancreatitis beyond 4th week, most of my problem has been made easy by Jahangir. He has really presented the studies very well. So for the paucity of some time and to give you the concluding message, my intention would be to skip most of the research trials, etc., and give you the carry home message. So for acute pancreatitis beyond 4th week, we have two problems. One is a pancreatic pseudocyst. And if this pancreatic pseudocyst has infection in it, we call it walled-off necrosis. So this gentleman, Dr. Todd Barron, he's a gastroenterologist par excellence. He created a paradigm shift in the approach and outlook how we should manage the fluid collections beyond 4 weeks. He gave this definition of walled-off necrosis. So what's a walled-off necrosis and how it is different from a pancreatic pseudocyst is the outcome. the pancreatic pseudocyst treatment outcome is much better than the outcome of walled off necrosis. So if you see this picture diagram, you will appreciate that in walled off necrosis, most of the pancreas gets destroyed. There is the pancreatic duct opens into the lesser sac and the collection there. The collection can be sterile, the collection can be infected as well. So there was situation when we were going into it, then they found that it wasn't only the lesser sac which was accumulating the infected material or sterile material. Sometimes the infected material was going beyond, sometimes in mediastinum, sometimes in the paracolic gutter, subhepatic area. So the management of this particular section of patients would be different again. We have labeled this as an extended walled off necrosis for our understanding and for the treatment outcome. So what was the need for creating this difference? Why a pseudocyst versus a walled off necrosis? If you see this treatment success in pseudocyst is up to 93.5% versus in WAN it is 63.2%. The adverse events are almost 3 times in both these situations. The need for interventions and length of stay is also significantly higher in WAN. So our more serious challenge is WAN as compared to pseudocyst. Pseudocyst is easy to manage, WAN is difficult to manage. So my co-speakers have already elaborated this point. If you have a simple pseudocyst, most of these pseudocysts will resolve. We need to address only hardly 15%. And for WAN, we have to address another 20% of these patients. And information concerning the integrity of the main pancreatic duct is also important to know because this will also determine the course of the events. So as to say that the pictures above in the earlier 4 weeks and then the later 4 weeks is pseudocyst versus WAN. So what should be the optimal timing? The optimal timing for this situation of 4 possible complications will be pancreatic pseudocyst, WAN, extended WAN, I have discussed about it, this disconnected pancreatic duct syndrome, and the other vascular luminal complications I will discuss in brief here. So what should be the optimal timing? We should try to delay, as Dr. Jahangir has very well mentioned. Even if the situation is beyond 4 weeks, we should try to delay, and if required then drain. There will be indications, and if you debride, if you are not able to drain it properly, if there is a collection still in lesser sac, and if it doesn't, you deviate from this principle, then you invite problems, which is death. So ideal intervention we discussed. So what are the possible indications for interfering in beyond 4 weeks? It will be persistent unwellness, gastric outlet obstruction. These are the physical effects of that pancreatic pseudocyst or walled off necrosis on the lumen. It can be pressure effect on the bile duct causing jaundice, abdominal compartment syndromes, ongoing acute bleeds, bowel ischemia, pleural effusion, pancreatopleural fistulas, etc. These are certain situations which needs to be addressed. And when you are addressing, then these points are very important. Are you addressing a pseudocyst? Are you addressing a WAN, or are you addressing an extended WAN? Therefore, we need a very nice imaging for this. And when you're imaging, then the biotechnology comes to our help. Beyond the endoscopy comes the endoscopic ultrasound, which further clarifies whether you're dealing with a WAN or you're dealing with a pseudocyst. So the possible treatment options for us are intervention radiology, endoscopy, and surgery. And then the possible means of treatment will be LAMS versus plastic stent. So if you have a pseudocyst to treat, the treatment of pseudocyst is relatively good, as we discussed in the previous slide. And when we compare it with the surgery, we find that the results of endoscopic treatment of pseudocyst is significantly better as compared to surgery, because as compared to surgery, there will be lesser hospital stay, lesser cost, no incision. The complication rate is also significantly less. So we can drain a pseudocyst by 2 ways. We can go transpapillary, that is through the ampulla of Vater, and we can also go through the transmural approach, which means that if there is a bulging pseudocyst on the lesser curvature of the stomach, then you can puncture the posterior wall of the stomach, enter inside the pseudocyst, and create a communication between the lesser sac and the stomach. The whole fluid comes into the stomach and gets drained per rectal. So this is the transpapillary and transmural approaches. So transpapillary drainage is good for a small pseudocyst, and it also helps if there is a pancreatic duct disconnection. You bridge it, so therefore the risk of recurrence is less. But if you have a bigger collection, then you would probably need a transmural drainage. And what will happen in transmural drainage? That we are going to puncture, as discussed, Then we will dilate the tract, and after dilating we'll place a stent, because there is possibility that the pancreatic duct has leaked into the lesser sac and it keeps on pouring the pancreatic fluid into the lesser sac. So we create a controlled fistula between the lesser sac and the stomach to keep the lesser sac empty. So here we can place stents, which can be a plastic oblique metallic stent. So what plastic stent or metallic stent, but prior to this there was an important step of creating a wide opening. So how much kind of balloon, which kind of balloon you should use. If the collection is less than 6 centimeters in size, then the balloon size should be less than 8. If the pancreatic fluid collection size is more than 6 centimeters, and if you are puncturing the transmural approach through the stomach, then it can go up to 12 to 15, but in the duodenum, 8 to 10 millimeters. So what to use, whether LEMS or plastic stent? They are comparable as long as we are managing a pancreatic pseudocyst drainage. LEMS is expensive, but it is easy to place. It cannot be left in situ indefinitely. So if you will convert a LEMS later on, after 4 weeks, you will have to convert it into a plastic stent if there is risk of disconnected pancreatic duct syndrome. So in my era of 2.5 decades of practice, I have gone through all these stages. There was a time when we were not doing anything and we were sending patients straight to the surgeon. Then came an era when we were interfering through the endoscopes, doing simple transmural drainages as described. Then beyond 2010 came an era of endoscopic ultrasound. So the biotechnology was helping us to provide patients more safety, less invasion, and more durability of the treatment. Therefore, EOS has more technical success even in non-bulging pancreatic pseudocyst. It also avoids intervening vessels, lower complication, identifies the debris. But if you have a non-bulging, if you have a good bulging, uncomplicated pseudocyst, and if you do not have a facility of EOS, you might as well consider the simple endoscopic approach. The second part of discussion, and which is more morbid and more mortal, creates more mortality, is one. So the statistics are quite clear here. 30% pancreatic necrotic patients will die, 80% will die if they have septic complications, and if we do not treat them, in spite of multi-organ failure, 100% of these patients will die. This is a bad disease to tackle. So we need to be very careful. A lot of communication needs to be established between you and your patient, because these are patients who have a big amount of mortality. So indications for interventions are infections, organ failure, intractable pain, outlet obstruction, and disconnected syndrome. Our treatment options are surgery, intervention radiology, and endoscopy. So as I said, in my 2 decades of experience, when I started practice, it was all surgery. But as Dr. Jahangir had very beautifully shown, in 2010 in NEJM the article came. They said if you just push in a tube inside the lesser sac through the retroperitoneal approach, and if you drain it, it significantly reduces the mortality. And this was the changing event, a paradigm shift in the approach how we were looking at the treatment of this particular section of disease, which has high mortality. Then came the endoscopy, then came the EUS, then came the LEMS, and now the mortality is significantly better than what it was in year 2010, because there has been a significant shift. So if we consider and if we try to compare between surgery and endotherapy, the Panther trial is also another landmark trial, and up to 2019 there is a big follow-up also. This also further states that endotherapy has a big role in providing better relief to the patient. And strategies for intervention. So our whole intention of treatment is to go from open to minimally invasive to endoscopic surgery. All these 4 studies are showing that if you take up a step-up approach in surgical debridement, then you go inside the lesser sac, clean it, and then place a SEMS or LAMS, keep it for 4 weeks. If there is a DPDS, convert it into a metal stent. The Panther trial in 2019, the follow-up, the longest follow-up, also endorsed that this particular approach, in spite of surgery, was more relevant to the patients, because it had significantly reduced the mortality, the cost, and interesting data came that the diabetes risk also would probably go down. Now what does the intervention radiologist does? A IR person places a drain through the lesser sac, through the retroperitoneal approach into the lesser sac. They can go transgastric, they can go transperitoneal, and they can go retroperitoneal as well. Now, it is a little I will exceed it beyond my topic. In earlier than 2 weeks also, you can use sometimes PCD if you septic complications are encountered. We have a beautiful study from PGI Chandigarh where they documented that it saves life, but the risk of fistula formation is high. Now, for intervention radiology procedures, they are good. They are reducing the mortality. But the problem is the external fistula formation is up to 27%. We need to do something about this fistula formation later on down the line. As compared to these PCD procedures, when endoscopy was compared, it had better response rates, lower rates of complications, and shorter stay of length in the hospital. So in the endoscopic treatment, we all started for Vaughan in last decade, in the early part of the last decade. Like a pseudocyst, we were going inside the lesser sac, we were like inflating a balloon, creating an opening, and then we were placing plastic stents. But we realized that a good number of these patients, up to 36% of these patients, we are complicating. So this was the era when something new came in, which was called the LAMS. This is a revolution, another revolution in the treatment of Vaughan. There were different kinds of bioflange devices which will go there and they will stick to the area. They give you wide big opening through which your scope can go into the lesser sac, and then it can create a complete wide fistula through which the debris will come out. If it doesn't come out still, we can go in and bring it out. So we have now sufficient data of Indian as well as outside which says that this is better than the other one. The step-up approach, just 30 seconds more. The step-up approach says that you just go in, almost like 75% patients do well, and if you do, even after debridement, we are able to cure 95% of the patients. Now the endoscopic approach is better than the surgical approach, and this is, I must mention one Orlando approach. The Orlando approach says that if you have a bigger collections, then multigated approach should be used. So does this mean that surgery has no role? I would probably differ on, that if you have a distant cyst, then it is of no use. Gastric bypass surgery, prior surgeries, it has no role. Then comes the minimally invasive surgery, which is now changing the scenario, but there are limited studies on it. Now, this is a very interesting data which I want to share. I have copied it from Dr. G.V. Rao's presentation, that what if the patient goes straight to surgery, then going through the IR, then PCD, endoscopy, and then the mortality increases if it is not a primary procedure. This is an interesting slide I found. I copied it and I wanted to share it with all of you. Another interesting presentation, a trial came from All India Institute, Dr. Garg's unit, which also said that surgery has still a big role, because if we intervene early and if the debris is less than 30%, then surgery has a big role. So carry home message, I would probably say that if it is less than 30% debris and if it is nearer to the stomach and duodenum, you can do endoscopy. If it is more than 30%, then consider open surgery or a laparoscopic surgery. MIS is better. But if it is beyond the stomach and duodenum, then, and if it is less than 30%, consider radiology or open surgery. And if it is more than 30% with infection, then of course surgery has a priority. We have disconnected DPTS, then we need to do connect this, and I'll not go into it. The only important thing is disconnected pancreatic duct syndrome has increased risk of recurrences, difficult to treat, and these are the patients which require more close observation. And the pancreatic fistulas happen into DPTS patients. So we have other vascular and bowel complications also beyond 4th weeks. So this is beyond the time limit to show this. And before I close, may I take this opportunity to invite all of you for ISG, Indian Society of Gastroenterology meeting, which is happening in Jaipur on 5th to 8th of January. So I'll request on saying that Padharo Mare Desh. Thank you so much for your kind attention.
Thank you, sir. Thank you for nice and lucid presentation. We conclude the session. Thank you.
Thank you, sir, and thank you all chairpersons. We'll start our next topic, pancreatic fluid collections. For that, I would like to invite Dr. Mahinish Gandhi sir, Dr. Chirag Thakkar sir, Dr. Apurva Shah sir, and Dr. Hardik Gupta sir as a chairperson. But before we start our next topic, I want to announce that Lunch will be started at 2 o'clock. Those who want to take in, but officially lunch break will be after this one topic of debate.
Taking the acute pancreatitis topic further, I would like to call Dr. Praveen Rai from SGPGI to talk on pancreatic fluid collections.
Actually, my talk, almost everything has been touched upon by Dr. Mukesh. So I think I'll just repeating many of these slides, but try to give you some crisp messages that you need to carry home. So the talk is basically pancreatic fluid collection. This has been talked of with less than 4 weeks. If you have a fluid collection, it's known as acute pancreatic fluid collection. More than 4 weeks, when a wall forms, which is a pseudo wall, it's known as pancreatic pseudocyst. Before 4 weeks, necrotic collection, it's known as acute necrotic collection. After 4 weeks, it becomes a walled off pancreatic necrosis. That's a time when you can drain if required. So, acute pancreatic fluid collection, what one needs to remember that all of these need not be drained. 70 to 90% resolve, 10 to 30% form pseudocyst, and out of these pseudocysts, 70 to 85% again resolve spontaneously. So earlier there was something known as rule of 6, which meant that pseudocyst more than 6 centimeters in size and more than 6 month duration needs to be drained. So this is now no more valid. So when does a pseudocyst need to be drained? Preferably after 4 weeks. It has to be symptomatic, infected and increasing in size. Or symptoms include signs of obstruction, persistent pain, early satiety, vomiting, GI bleed, ascites, or massive pleural effusion. So these are the different approaches that one needs to know. It can be endoscopic, percutaneous, open or lap cystogastrostomy. So endoscopic approach, that is transmural or a transpapillary, is the first line of therapy that everyone needs to remember, provided it can be done safely. So it has got significant advantage over surgery and percutaneous, especially when the cyst is single. It has a very high success rate. When the wall distance between the cyst and the stomach and the duodenal wall is less than a centimeter, results are good. So earlier we used to drain this pseudocyst with a sidewing scope, which is now no more done. It has to be an EUS guided drainage, not the drainage with a sidewing scope. And these are the reasons why we should be doing it under EUS guidance. So if this is just a small video to say how we do it. Okay, we'll just skip this. So transpapillary drainage, what are the indications? Cyst has to be less than 5 centimeter and you need to place a PD stent, which if bridges the gap of the pancreatic disruption, it has got a high success rate. The size of the stent that you need to choose is that which can fit the PD nicely. The main risk, however, is a secondary cyst infection that can happen. So this slide just tells you that why we should be doing an endoscopic drainage and not a percutaneous drainage. The reason is the reintervention rate is less with endoscopic drainage. Moreover, the length of hospital stay is less when patient is subjected to endoscopic drainage rather than a percutaneous drainage. Again, the comparison with surgery, again a very, very important 2 studies. One is a randomized trial and another is a case control study, which tells you that the length of hospital stay is less, recurrence is less, and the cost is less when you do an endoscopic drainage vis-a-vis surgery for a pancreatic pseudocyst. Mind you, this is for pancreatic pseudocyst. This slide has been shown earlier. There are certain limitations where endoscopic drainage obviously can't be done. When it's a distant pseudocyst, expertise is not available and there is an altered anatomy. So this is again a world of pancreatic necrosis. You have heard about it lot many times. There are certain indications for intervention in world of pancreatic necrosis. One is a proven infected pancreatic necrosis or a clinically suspected infected pancreatic necrosis that has ongoing organ failure for several weeks despite optimal medical therapy, or the organ compression similar to that of a pseudocyst, or an abdominal compartment syndrome. So these are the reasons why you should be draining your WOPN, and not all WOPN need to be drained. So this again study just tells you that the incidence varies from 2 to around 40%. Again, the treatment options remain the same as of pseudocyst: endoscopic, percutaneous, and surgical, which can be open or a ward procedure. So this slide just tells you that WON are managed with all the different options, either conservative, PCD and surgery, surgery alone, endoscopy alone, and endoscopy plus PCD. So these are the different options that are done. We as gastroenterologists resort to endoscopic therapy, and what we do is primarily a drainage, which can either be with a plastic stent or an endoscopic nasocystic drain, or we use a self-expanding metal stent, or we use a lumen-opposing metal stent, and the cost of the stent increases as you move from plastic to lumen-opposing metal stent. If this drainage doesn't work, you resort to a necrosectomy, and this is usually done with a self-expanding metal stent. So necrosectomy again involves a technique which again is for expert endoscopists. Primarily we do debridement, extraction of necrotic debris, and irrigation. So these are three important steps that we practice while doing an endoscopic necrosectomy. There's again a video, I don't know whether to play or not again. So this is play. So as you can see, there's a large necrotic debris here inside, and we usually use different devices, maybe a snare, maybe a Rothnid, and to remove this necrotic debris. And I can tell you this is quite rewarding that without resorting to surgery, you can remove such necrotic debris, and the patient condition definitely improves after this. So summary of endoscopic drainage, again success rate to the tune of 80 to 90% clinical success and technical success. This is achieved whether you use a plastic stent or a metal stent. This is for walled-off pancreatic necrosis. So these are the different stents that we have. Obviously you have a question in your mind which of these you will be using. So I have just summarized the different systematic review and meta-analysis which tells you that you can use either. So as you can see here, 3 of the meta-analysis show that they are equal, while 2 show that the metal stent may be preferred. So in general, the AGA has recommended that you should be using a metal stent when you are trying to do a drainage of necrosectomy, walled-off pancreatic necrosis. So if you see this surgical necrosectomy, again, the outcomes, the mortality rate has varied from around 27 to 100%. So the very high mortality rate with surgical necrosectomy, and over a period of time, if you see what has happened, in 1925 it was said that recovery from the disease apart from the operation is so rare that no case should be left untreated. This was somewhere in 1925. Now what you have is 2017, surgical necrosectomy is almost obsolete. So again, for open necrosectomy, the percutaneous route or an endoscopic route are predominantly used for the necrosectomy, and surgery is rarely needed. It may be required when there is total empty cutoff, ERCP, and inability to access the primary pancreatic duct. So basically in condition of disconnected pancreatic duct syndrome, these are the reasons why you may resort to surgery. So again, these are the 2 important landmark trials in Lancet and Gastroenterology 2018 and 19, which tells you that the endoscopic step-up therapy is feasible and equally effective with lesser complications. So this is again a Cochrane review in 2016 using the different approaches of management of walled-off pancreatic necrosis, and the conclusion that was drawn from this Cochrane review was that endoscopic minimally invasive step-up approach has fewer adverse events but increases the number of procedures. So what has happened, if you see this very, very important slide, this just tells you that the mortality when you use different interventions in Waldorf pancreatic necrosis, open necrosectomy to the tune of 56%, endoscopic minimally invasive approach, mortality again is there but 10%, and minimally invasive step-up approach, which can be percutaneous, is 0% mortality. So step-up approach primarily involves delay, drain and debride. So what does that mean? That if you are using an endoscopic approach, initially you just place a plastic stent or a metal stent. If the patient deteriorates after a period of 48 hours to 72 hours, then you resort to necrosectomy. So that's what is delay, drain and debride. That is 3 Ds which are very, very important to remember. However, there are certain conditions, certain factors that need to be considered when planning an intervention. As I mentioned, endoscopic approach may not be used in all patients. Local expertise is very, very important. You need to see the content, solid versus predominantly fluid. If it's predominantly solid, more than 50%, normally we don't resort to endoscopic necrosectomy. If it's liquid, you can resort to endoscopic or percutaneous approach. Anatomic location, again, very, very important. So the trends which need to be followed is delayed rather than early, aggressive now to minimally invasive, and single step to step-up approach, and percutaneous to endoscopy. So these are the new trends that need to be followed. So this approach based on anatomical location that one needs to know. If it's a central retrogastric collection, endoscopic transgastric or laparoscopic transgastric approach can be used. Retrogastric with paracolic gutter extension, you need to do a PCD with step up to videoscopic retroperitoneal debridement. Retrogastric collection with extension to right of mesenteric vessels, you can resort to either endoscopic, lap, or may need open debridement. So this again Gastroenterology 2020, which again suggests the same, that initial management, if it's a central collection, can just be an EUS guided LAMS placement resorting to necrosectomy if the patient doesn't improve. If you have a large paracolic gutter extension, percutaneous approach is usually preferred rather than surgery. So this again slide tells you the same, that less than 4 weeks, if the patient is symptomatic, worsening condition of Waldorf pancreatic necrosis, usually you resort to percutaneous drainage, though now there are reports of early drainage with endoscopic therapy as well. However, more than 4 weeks, usually it's endoscopic approach, and if the collection is not is paracolic, then it is a percutaneous approach. So to summarize, only symptomatic pancreatic fluid collection merits drainage. EUS guided drainage is the preferred modality for drainage. Before drainage, rule out cystic neoplasm or pseudoaneurysm. Use of single, multiple plastic stent suffices with high efficacy in pseudocyst. Fully covered cell expanding metal stent is more appropriate for Waldorf pancreatic necrosis. Now LAMS, endoscopic step-up approach is preferred in Waldorf pancreatic necrosis. Thank you.
A very nice presentation, Dr. Praveer. I would open the house for any questions if anybody has any questions to discuss.
Hello. What are your criteria to remove the metal stent, and how long you keep it once you're doing it?
Yeah, so now according to guidelines, you should be removing this after a period of around 4 to 6 weeks. So the concern that you have with the lumen opposing metal stent is the risk of bleed that may happen if you keep it for long. So normally it should be removed at a period of around 4 to 6 weeks.
And how many of your patients, suppose you have done a EUS guided metal stent drainage, how many of that patient and which kind of patient require a surgical drainage later on?
So what I can tell you is that if it is a centrally placed collection, that is just single collection, centrally placed, necrosis less than 50%, this all can be managed endoscopically. Problem happens when you have a large central collection and maybe some collections in the paracolic gutters also. There you may resort to, you may need possibly percutaneous drainage, and if these patients don't respond, only then these patients are subjected to surgery, which we keep as a last resort.
Okay, thank you. Any other questions? So, thank you, Dr. Praveen.
Thank you.
We'll invite
for the chronic pancreatitis debate, endoscopic management, or we are over-treating the ERCP. I'll call Dr. Yogesh Kalla for endoscopic management.
After this debate, we'll have 15 minutes of lunch break. So those who are in auditorium, they can take lunch.
So this next topic is like a controversy again. Because science is evolving, concepts are changing, technology is coming in. So there will be differences. Because over a period of time, we have lived through the journey of 2 decades of improvement in biotechnology. Annie? So the topic given to me in chronic pancreatitis is that are we overrating ERCP? Are we saying that we can do everything by ERCP and surgery has no role? Whereas the convention says that surgery is the gold standard for treating complications of chronic pancreatitis, and most of these patients should land on a surgeon's table. But who wants to undergo?
So before debate, you are concluding that surgery is in.
So who wants to go to the OT table, because we have a disease, which is, we are not going to offer a cure, we are going to palliate either way. So, I mean, surgery, a complication after surgery comes back to an endoscopist for treatment. So even if an endoscopist treats a situation, and if it doesn't work out well, he can still go to a surgeon without any major disadvantages for the surgeon to operate and for the patient as well. So we have following problems in endotherapy: ductal calculi, strictures, we have ductal leaks, pseudocysts, biliary strictures, inflammatory masses, and evolving, this is most interesting part I consider here, is exocrine and endocrine function changes on the treatment. So long-term follow-up says that the pain relief, which is the main reason for these patients coming to a doctor, has a 60% relief with endoscopic therapy. Now, if you visit literature, there is a lot of heterogeneity in the data available. The data says that the etiological issues in Indians, in the West, the major etiology is alcohol for chronic pancreatitis, and in the East, the major etiology is idiopathic. We are somewhere in between, and ours is basically few alcoholics and few idiopathic. Why this difference? Because the alcoholic patients will have predominantly stone disease, and the idiopathic will have predominantly a stricturing disease, and the middle people will have a stricturing plus a stone disease. So when you go through the trials, they say that surgery is obviously better in a stricturing disease, because for an endoscopist, he will have to do it repeatedly. Most of the major studies, when they were conducted in an era when ESWL and pancreatoscopy were not available. Now is the era when you have ESWL and pancreatoscopy. So predominantly for us, Indian population where stone disease is predominant, I would probably say that endoscopy has a reasonable role. So that is the West versus East data. So endoscopist versus surgeon bias. So if you see the literature, there is a lot of literature where says surgery is better. The main author is a surgeon. Endoscopist says endoscopy is better. The endoscopist is a major author for the subject. Therefore, there is a bias there also. So changing technology I have already discussed, and evolving concepts, which is like, can our treatment modify or improve the exocrine and endocrine, which is like diabetes and steatorrhea. So there is a high success rate with endotherapy, can be repeated without extra cost. Results are comparable to surgery. Failed endotherapy does not hinder going patient to surgical table. So ERCP for diagnosis has no role, because EUS and MRCP, and particularly secretin-induced MRCP, has better advantages. So papillary sphincterotomy for a minimal dilated disease. There are two kinds of chronic pancreatitis, one with a dilated pancreatic duct, one with a non-dilated pancreatic duct. They say that if you do simple sphincterotomy, 64% patients will have relief. Of course, out of this, 14% will have restenosis over 2 years' time. We can do it again for them, because it is a palliation. So the MPD strictures are defined as high-grade narrowing. There's more than 6 mm beyond the stricture, failure of contrast to flow, presence of pain while pushing a contrast is the criteria for saying that patient has a problem. So endotherapy, there is no question asked. Endotherapy is ideal for a single stricture in the head, But for multiple strictures, there are no questions asked that these patients should go to a surgeon's table. If you go to, this is a very important landmark trial which is called as a Costa Magna trial, which said that if you place a stent, patient has a relief. Over a period of time, the patient has recurrence of pain. You place multiple stents and keep the stents for 1 year. Almost 94% of these patients will have no pain down the line. And for single stent, 32%, here almost 95% patients will have no pain. So this is a very important study. But for those patients who still get pain after multiple stents are called refractory patients, they should ideally go for surgeon, or there is a new concept which is dropping in now, is a fully covered metallic stent, so which is not a treatment modality, it is under trials so far. Endoscopic treatment of chronic pancreatitis, August 22 ESG statement very clearly says dominant PD stricture should be treated with a 10 French stent exchanged and for 1 year. The recurrence rate is just less than 32% over 2 years. Multiple plastic stents can be placed in, which is like Costa Magna trial. Uncovered stents should not be placed in MPD as of now because the data is not adequate. Now if you have multiple strictures, refractory MPD strictures, ERCP failures, these are the patients which should obviously go to a surgeon's table. Now pancreatic ductal calculi. So what about this? This is our problem. This is our major problem. We have mix of these two, but major problem is pancreatic ductal calculi. So if you have stones which are like up to 5 millimeters, you can do a sphincterotomy and retrieve it by a simple ERCP. But if you have a big stones, so this was the particular group of patients which were going to surgeon's table earlier, but with the advent of ESWL, then most of the patients can be adequately treated. Now there are multiple trials and multivariate analysis which supports good use of ESWL in this situation. Unfortunately, the chronic pancreatitis stones are hard, speculated. They have with or without strictures. Majority are radio-opaque, minority are radiolucent, and sometimes have complex pathologies. So ESW and laser lithotripsy are two new things which have come up in society now, which are really revolutionizing the change in outcome of the treatment. And alternative methods can be pancreatoscopy. You take your scope inside the pancreatic duct, you see the stone and fire it and pulverize the stone. Unfortunately, the S-shaped PD, the strictures, this endoscopic approach, the pancreatoscopic approach is not really popular as of now, though the data has started dropping in, which says that this World Journal Gastroenterology publication, which is from September 2020, where efficacy of pancreatoscopy in a review meta-analysis has been shown. But with the newer scopes, which will now, almost the company is about to provide us a better scope with a thinner the scope, more maneuverability, bigger channel, we will now be able to go inside the pancreatic duct, see the stone right in front of your eyes and pulverize it with a laser. So these are a few landmark situations which are changing the scenario. So strictures can be reversed. So I will just cut down because for shortage of time. I would like to address benign biliary strictures. This is another problem. So if these patients have more than twice the upper limit of the alkaline phosphatase, these are the patients who should be treated. Biliary stones, asymptomatic alkaline phosphatase, if it is more than 2-3 times upper limit of normal, we should subject them for ERCP stenting in the common bile duct. For these patients, multiple stents can be placed to achieve wider lumen at the lower end of bile duct. So if you have benign biliary stricture and if it is failure of therapy, it is for surgeons to operate, but multiple plastic stents can be provide a successful relief in up to 95% of these patients. Stent exchanges are performed every 3 months for 1 year. So this is Catalona et al. Study which proves again that if you have multiple stents, then you can have an adequate opening for a longer duration of time. The success rate is reported up to 92%. Now, pancreatic ductal leaks, you can have fluid collection, pseudocyst, ascites, pleural effusion and fistulas. So if you see these fluid collection, no surgeon would like to take up these patients because the surgery is morbid, you have to do pancreatectomy for these patients. For us, for endotherapy, you just have to do a pancreatic sphincterotomy, do a good pancreatogram, assess the location of the leak, place a stent, and almost up to 90% of these patients, the leak would stop if you are able to bridge the disruption. But if you're not able to bridge the disruption and if you're keeping your stent just proximal to the disruption, 50% of these patients will get a relief. and there will be a short transpapillary stent if you are able to put. Still 40% patients will have improvement in their leaks. So for these patients with complete transection, stenting is not possible. These are surgical candidates. There is no debate about it. So pancreatic pseudocyst in chronic pancreatitis is the result of disruption, and because this disruption is seen in up to 40%, they can easily managed with the transpapillary approach, doing a sphincterotomy and placing a stent. So symptoms because of pseudocyst would result because of compression. The prophylactic treatment, pancreatopleural fistula, if the cyst size is more than 5 millimeter, then and over 6 weeks compressing major vessels, then you can drain transgastric or transduodenal, as we have discussed in our previous slide. So I would probably skip this slide also, and because if you have a smaller cyst, then there is no point sending these patients for surgery, because the success rate is up to 95%, recurrence is less than 10%. Now, what are the benefits? This is less invasive, offers good results, associated with low morbidity, mortality, can be repeated. It does not interfere with surgical decisions. It is therefore advisable to offer endotherapy as first line of treatment for properly selected patients. So therefore, to conclude, I would now say that if you have a patient who has predominant stricture in the head, who has a pancreatic leak, who has a radio-opaque stone, predominantly in the head and body region of the pancreatic duct, these patients need not go to a surgeon. The use of ESWL, the use of pancreatoscopy, the use of simple ERCP if the stones are small are good enough. But yes, if there is a patient who has a disease in the tail, if there is a patient who has, in spite of placing stents, we call them a refractory stents, it's not responding, they will obviously go to a surgeon's table. Pancreatic leaks, no discussion about it. Initial treatment will be endoscopic. So I leave this to the house to decide which therapy is better. But in nutshell, to say that if it is a selected situation, then the results will be better. So these are the shortcomings of ERCP. If you try and meddle with a stone which is more than 10 millimeters, because these are stones which are like impacted within the side branches of the pancreatic duct, it is difficult to take your accessory beyond the stone to bring them out. There are difficulties if your basket gets broken or trapped, it's a serious complication. If there is a PD leak because of the procedure, it's a complication. So there are shortcomings of the ERCP as well. Now the data is also now dropping in. If we saw the earlier data, the NEJM trial from 2004 till 2010, the data was predominantly favoring the use of surgery. But with the advent of pancreatoscopy, with the advent of ESWL, with the changing epidemiology of the disease, if we talk about our country, we should keep endotherapy in consideration for all the patients who are landing onto a physician, surgeons or a gastroenterologist table. Thank you very much for patient listening, and I'll be here to answer to questions if required.
Sir, I appreciate your view on surgical versus endotherapy. But as you say that now because of advent of pancreatoscopy, the plan is changed, but your conclusion is almost same like before 10 years and now down the road, because head dominant disease, stricture and single stone. So what difference you made from with the advent of pancreatoscopy? Because the things are same like.
No. It's going to make a hell lot of difference. In the earlier era when I started my practice, the only modality what I had to tackle a stone which was like 7-8 millimeters in head of pancreas, which was stuck, was to do a sphincterotomy and place a stent. Because my wire will not go beyond the stone, my basket will not go beyond the stone so as to catch it and bring it out. Though there is a dilated pancreatic duct, but now we have a pancreatoscope which goes inside the common bile duct. So as we are seeing each other, we are seeing the stone right there, we have a laser fiber and we just pulverize it there and then. So it makes a lot of difference. So therefore the technology is changing. We did not talk about ESWL in 2005 to 2010. For all these radio-opaque stones, the scenario has almost changed. So, I mean, if you go through the trials and now the multivariate analysis is also available about ESWL, it has significantly changed the outcome of PD stone situation. I tell you, the disease is so varied that there is a difference between the epidemiology and presentation of chronic pancreatitis and PD stones in North India and South India as well. So I am a pass out from Mumbai, so when I was in Bombay, the number of pancreatic cases which we were doing in Bombay as compared to the pancreatic cases particularly for PD stone disease or CPN in Jaipur are relatively less. So there are no statistical data available, but this is a practice assessment that this disease is more predominant in South.
Yes. So, another question, sir. As you said, costa-magna trial, putting a single stent is not helping, putting a 2 stent, 3 stent. So, what will be the reason? Because our idea is to decrease the intraductal pressure.
Right.
So, putting a 1 stent, it's not helping us. So, how putting a 2 stent also not helping? So, what will be the reason for this?
Nice question. These are fibrotic strictures. The chronic pancreatitis strictures compared to biliary strictures are different. They behave differently. They are, etiology-wise also they are different. These are tough strictures. So what happens here that if you place a 10 French stent, a 10 French stent is 3 millimeter size. If you place 2 stents, then 6 millimeters is size. So you leave the stent inside for 3 months. So you have a traction on the stent for up to 6 millimeters in size, which is a normal size of pancreatic duct. And when you bring them out, because of this prolonged pressure effect, the strictures continues to behave comfortably, like they don't reoccur.
It may be reason also that they have a side duct stones and it's not really, that may be possible.
No. For side duct stones, which is like parenchymal calcification, side duct stones, inflammatory mass, there are no second thoughts. These are the patients for surgeons. They are not patients for us. We should better not deal with them. Therefore, to say that when you have a patient of chronic pancreatitis, symptomatic patient of chronic pancreatitis, we have to have adequate radiological, like a good CT MRI, if required endoscopic ultrasound information, accumulate all that information, discuss with your surgeon, and then take a call which way to go. I am only saying that if it is a selected situation, if you have one single stricture in the head of pancreas, if you have one stone 10 millimeters in head of pancreas, say presuming that it's a pancreatic leak, presuming that it's a pancreatic pseudocyst, these are situations which can easily be tackled by a procedure which is like 20 minutes, 30 minutes procedure. If required, you can repeat it. It has no major morbidity also. So as to say that this particular subsection, if properly selected, will give better results. But if you start dealing with each and every situation, then you will obviously invite problems.
Another sir, you have a stricture in the head of pancreas. In spite of putting a plastic stent, have you experienced about the fully covered metal stent? You see the difference in outcome in the patient? Plastic stent versus fully metal stent. As you say, the fully covered metal stent is also upcoming.
No. I have, so far in my career, I have never placed a metal stent because metal stents in chronic pancreatitis stricture are still under trials. They are not, available to be used as per the guidelines. But the data is encouraging because AIGs, they have a few number of patients they have done and the data is encouraging. Maybe like when we meet into like 5th session of the advanced endoscopy workshop which Yogesh will organize, we'll have some better information about it. Okay. As of now, it is not a routine clinical practice.
Can I add something to Dr. Kalla, please?
Yeah.
So, as you ask what has changed, why the plastic stent 1, 2, 3, the aim of stenting is to gain an adequate lumen size for decreasing the intraductal pressure or to get an adequate size of the stricture remodeling. And for that, initially when the stricture is very tight, you start with the 1, 2 and then followed by 3 and 4. And now there is a reasonable amount of data available, one paper from AIG also. The technical success in the multiple plastic stent versus metal stent is same. The difference is with the one metal stent you require ERCP only once. But when you are putting the multiple plastic stent, you may require 2 or 3 ERCPs. So the difference is the number of ERCP. Cost-wise, more or less both are same. Only thing is you put one-time stent and you achieve the success rate of 92%.
This kind of patient, they feel bad even after surgery also, as you have
the 5 years follow-up, I think is 65 to 70% remodeling.
Okay, thank you. Yeah, sure.
Yes, please.
I'll invite Dr. Harsh Shah for the surgical counterpart for the debate.
First of all, I would like to thank Dr. Yogesh for this opportunity. Actually, my talk is relatively simple because the data is in the favor of surgery, and what my predecessor said was all about Mainly the studies were more of a prospective trials, but what I am going to talk about is all randomized controlled trials. So let me reframe the question. Do we all need surgery? Actually, we all don't want surgery. If the question is the surgery superior to endotherapy in the present situation, then I would say yes, definitely surgery is superior. As we all know, chronic pancreatitis is a chronic fibro-inflammatory condition. Basically it's a self-perpetuating cycles of chronic inflammation. Doesn't matter whatever the etiology was, but ultimately we end up in PD strictures and stones. As such, the indication of intervention is very well established. The most common indication of intervention is pain. There is no doubt that pain becomes the indication. There have been very many etiologies why does this pain occur, but there are many hypotheses. We should not go in detail of this right now, but there are certain evolving indication of interventions, like whether we can prevent the development of endocrine and exocrine functions in chronic pancreatitis, whether interventions can prevent this. This is the topic of discussion right now. So I am going to compare surgery versus endoscopy in following 4 headings. One is the efficacy, second is safety, third is cost effectiveness, and fourth is applicability. The efficacy means whether it's useful in control of pain in short term as well as long term, whether the endocrine and exocrine insufficiency can be prevented, and whether the quality of life can be improved. This was the first randomized controlled trial published in 2003, which showed 5-year follow-up data, which was quite in favor of surgery, that surgery was superior in pain relief as compared to endoscopic therapy. Weight gain was also better in surgical arm. However, this trial was disadvantaged by the factor that they did not use ESWL in the endotherapy group. They just used ERCP sphincterotomy stenting. So to overcome that trial, another trial was published in 2007, NEJM, where they head-to-head comparison between endoscopic and surgical arm, and what they found was that here the advantage of this trial was they used ESW as well as ERCP. Less number of patients, 19 and 20 in each group. What they found after 2 years of follow-up was that there was complete or partial pain relief was better in surgical arm. Number of therapeutic re-intervention, as we all know, there will be more intervention in endoscopic arm as compared to the surgical arm. There was significant difference. Conversion, there were 21% of patients were converted to surgery at the end of the trial. Technical success, which was defined as complete duct clearance, was achieved in 100% of the patient in surgical arm. Complications were not different between the two groups. In fact, if you see the data, complications were less in surgical arm. The quality of life was better with surgery. In fact, the trial was prematurely ended. The reason being there was significantly better result in surgical arm. So it was unethical to continue the trial because the results were quite significantly in favor of surgery. The same trial published its 5-year data, and in the 5-year outcomes were almost similar. Sorry, something is wrong. In the 5-year outcomes were actually almost similar. There was better pain control at the end of 5 years in surgical arm, and there were higher number of re-interventions in endoscopy arm. Animation is not working. एनिमेशन आएगा नहीं रहा So in the same trial, they also checked about the cost-effective analysis. As far as everyone would be thinking that surgery would have higher cost, but in this same study, they found that endoscopy has higher cost as compared to the medical treatment. The reason being the number of re-intervention, hospital admissions and all. So as far as economic perspectives are concerned, surgery is definitely a better choice. Now, as these two trials were at some disadvantage because they were done probably 15 years back, but we have one recent randomized controlled trial which is published in 2020 in JAMA, which goes by the name of ESCAPE trial. That trial also concluded at the end of 18 months of follow-up that surgery is better at pain relief, as well as median number of interventions, re-interventions were higher in medical group as compared to the surgical group. There was a decent number of patients in this trial. Now we'll talk about certain meta-analysis and Cochrane review. In Cochrane review, they also concluded that this is a Cochrane review of RCTs that we have presented. They came to the conclusion that surgery is favored as far as the pain control is concerned, and the morbidity mortality is almost equal. So morbidity and mortality is not high in the surgical group. It is almost equivalent in endoscopy as well as surgical group. Another meta-analysis published in 2022, it came to the same conclusion, which I would not like to repeat, but there was an important aspect which was shown in this study, was that if you look at the patients who had no pain relief, those patients who did not get any benefit from the procedures, their number was higher in endoscopic group. Another meta-analysis of randomized control trial published in 2020, it came to the same conclusion that surgery is higher. Surgery provides better pain relief for chronic pancreatitis. One recently published meta-analysis 2022, which apart from including 3 RCTs, it also included certain other prospective trials. Total number of patients 570. It came to the conclusion that higher overall pain relief in surgical group. There was lower endocrine insufficiency in surgical group. However, there was no difference in complications. There was a way back in 1993, an article was published in Annals of Surgery with an interesting title, that progressive loss of pancreatic function in chronic pancreatitis is delayed by main pancreatic duct decompression. Probably this is one of the wisest statements that you will find in the literature. Sometimes we'll have to go back into the history and we have to learn from it, rather than trying to reinvent the wheel. That basically, if you drain the pancreatic duct, it is going to give you a better functional outcomes. So the conclusion of the study was that functional loss was delayed by the surgery and what they suggested was drain before irreversible parenchymal damage and functional impairment has already set in. Another good trial, which was also an old trial, which tells us that analysis of surgical success, they analyze the surgical success in preventing recurrent acute pancreatitis. So if surgery was successful in preventing recurrent admissions with recurrent acute pancreatitis. So what should be the optimal timing of surgery? There was a very good trial which was published a few years back. It looked into patient undergoing surgery within 3 years of diagnosis of chronic pancreatitis versus those patients who undergo surgery after 3 years of chronic pancreatitis. What they found was that most of the patients, they had higher complete pain relief in the early surgery group, and those patients also had better endocrine functions, and they also had better quality of life. An article on same tone, which included 266 patients with 62 months of follow-up, it showed that the patient who had better pain relief are those patients who underwent surgery within 3 years of that diagnosis. There was no preoperative opioid use and those patients who had received less than 5 endoscopic intervention. And there was lower endocrine insufficiency in early surgery group. So basically what I showed was there were multiple randomized control trial, there was multiple analysis which are in favor of surgical treatment of chronic pancreatitis. But contradictory to our results, what guidelines say is endoscopy should always be tried first, which is quite unusual. So Now, there might be the guidelines, because the guidelines may be thinking that surgery is very, very, very risky in this scenario. Mind you, this is not an acute pancreatitis. This is not a condition where patient is in cytokine storm, where we want to avoid surgery. This is a chronic pancreatitis, which is a very controlled situation. Our surgical procedures are very much standardized, like in phrase, like Baggers, LPJ, they are very standard procedures. They have been performed over the last 30 years. Surgical steps are very standard. But in endoscopy group, we cannot say this. In endoscopy is evolving. We don't have any standard steps as of now. And as far as surgery goes, it's very easy. Like it's a very easy steps. Once you go in, open up the lesser sac, open up the duct and do the anastomosis. It's a very easy, fast surgery, and there is no anastomosis. Anastomosis rarely leaks in chronic pancreatitis. So what are the potential benefits of early surgery? One can say that once you can preserve the pancreatic tissue, if you are not resecting it, you are just diverting the pancreatic duct, then you might be able to preserve the endocrine and exocrine function in the long term. You can reduce the narcotic usage, and that has got many side effects like addiction, hyperalgesia, narcotic withdrawal syndrome. And one more important aspect which I would like to highlight is the development of cancer. Whether if by preventing recurrent pancreatitis, can you prevent cancer in this patient? That is a very important topic to be researched in the future. So as far as, so basically all the question marks are actually thumbs up. They have been changed probably by the computer. So, so my conclusion from this debate is that pain relief is better. With surgery gives you better pain relief, better quality of life, better cost effective, and success rate and reintervention rates are lower, are better with surgery. However, both, that is surgery and endoscopy, are comparable when you are thinking about endocrine exocrine insufficiency, when you are talking about complications and mortality rate. So it doesn't mean that endoscopy is not always required. Endoscopy has its own place. As far as my indication of endotherapy are concerned, I will go for endoscopy when there is a small ampullary stricture, there is a stricture in the head and neck with limited stone load, and there is no stricture and there are only stones, and symptomatic cirrhosis in portal hypertension. So this is not an acute pancreatitis. We should not go for a step-up approach. It should better to go ahead with surgery because it's a one-time effective and durable procedure, and there cannot be any effective substitute for draining a pancreatic duct completely. Thank you.
So, thank you, Dr. Harsh. We'll have only one question or argument. So, Dr. Manish and Dr. Chirag, both of you are very senior surgeons. Based on Dr. Mukesh Kalla's talk, what are, apart from the indications which Dr. Harsh has mentioned, what would you like to add indication of endotherapy, or according to you, only indications mentioned by Dr. Harsh is enough? And I would like to request Rajesh Puri sir to defend what you tell.
No, I fully agree with Dr. Kalla that head duct disease stricture, that probably will go for endotherapy. Another, I will bet that a small duct disease also, I prefer that they should go for endotherapy first. Because small duct disease after even surgery also it's difficult to defend, and they will come with the repeated problems.
Actually, sir, to be honest, small duct disease is even difficult for endoscopists to treat also.
Yeah, so question to my colleague is, like he said, pseudocyst with the portal hypertension, endoscopy is the treatment. I think the pseudocyst, the only one-and-one treatment is endoscopic treatment, and there isn't randomized studies available. One stent putting 5 minutes job is over in a patient of chronic pancreatitis. You don't require a surgical intervention. What the surgical colleagues give, they give a bigger stoma. I don't think size matters. What required is the appropriate drainage, and endoscopy is able to give. There is a randomized control trial published in GUT 2012, and there's a comparison between endoscopy and surgery. And the advantage of endoscopy is better quality of life, less duration of hospitalization, and low cost in comparison to surgery. Technical success and the treatment success are equal in the surgical group. Second point which I want to highlight, my colleague has said that endoscopy is evolving. I don't think endoscopy is evolving. Endoscopy is there right from the beginning, as he himself has shown the data, and there is nothing much which has been added. There are definite indications for endoscopy. There is a definite indication for surgery, I do agree, and which as a gastroenterologist follow. We don't treat all cases of chronic calcific pancreatitis with endotherapy. We send the patient for surgery. And the last, unfortunately, in spite of so many evidence, so many surgical colleagues come to us who has chronic pancreatitis or their relatives has chronic pancreatitis, but they came for endotherapy. They don't subject them for surgery. I don't know what is the dilemma for this.
Question to both of you. So which patient will refer for the surgery and which patient will refer, suppose it comes to which patient you refer for endotherapy?
So patient with the multiple stricture or patient who has a large ductal stone disease mainly in the body and tail of the pancreas. Definitely I refer these patients for surgery. But patient who has a ductal disease, much stone load in the head of the pancreas, single stricture in the head of the pancreas, I think it can be very well managed with endotherapy, which is less invasive and give the equal outcome as surgical colleagues.
Yeah. I had already mentioned my indication of endotherapy. If there is a small stricture in head and neck with limited stone load, or there is an ampullary stricture, or there are multiple stone without any stricture, it can be managed endoscopically.
I think both are complementary to each other, they are not competitive. I think that is important.
That is correct. That is correct.
Regarding patients who are having pseudocyst in chronic pancreatitis, I would like to ask that if you are draining the pseudocyst, would you still go and drain the PD also? Or,
so this is a dictum when you are dealing with the pseudocyst with chronic pancreatitis. You not only deal with the pseudocyst, but you also deal with the ductal pathology, that is a stone in the stricture. Otherwise, these patients are going to develop again pseudocyst. So this is mandatory to tackle the pancreatic duct either in the form of stone disease or with the stricture. Thank you.
Thank you, Dr. Rajesh Puri and Dr. Harsh for a wonderful discussion.
Now we'll be starting our pending sessions. So the first session which we are going to start is chronic pancreatitis medical management by my very close friend Dr. Zahir Nabi, who is from Asian Institute of Gastroenterology. He will discuss ideal and non-ideal candidates for medical management. And I would like to request our chairpersons, Dr. Vaibhav Sutharia, Dr. Rajiv Bansal, Dr. Manish Agrawal, to please come on stage. Dr. Rajiv Bansal and Dr. Manish Agrawal, please come on stage. With the permission of chairpersons. Thank you. So, my job today is next a few minutes I'll be discussing about medical management of chronic pancreatitis. I'll try and avoid what has already been discussed. So next few slides I'll be discussing about medical management. Pain, mainly the pharmacotherapy related aspects of chronic pancreatitis. We have already discussed endotherapy and surgery and exocrine insufficiency as well. The first thing I want to tell you is that pain in chronic pancreatitis, there is nothing more funny than that. And the main reason being there are so many etiologies reasons why pain can occur in chronic pancreatitis. The response is unpredictable. Means the pain may not correlate with severity on imaging. You may find multiple calculi, but the pain may be almost negligible. On the other hand, there may be minimal changes, but then the pain may be to a great extent. And ductal clearance does not mean that the patient is going to get relief. Maybe you clear the duct with stones by endoscopic treatment or surgical treatment. It does not guarantee pain relief. So this is very important to remember. And this is why it's impossible to get almost 100% relief, means relief in all the patients. The reason being that there is wiring problem, there is plumbing problem, there are neuropathic changes, and there are many things which cause pain in chronic pancreatitis. Ductal hypertension is only one reason, only one of all these 11 reasons why patient with chronic pancreatitis may have pain. So let's discuss the pharmacological management of chronic pancreatitis. The first is, before you proceed for drugs, it's very important that the underlying etiology, smoking has come to be a big reason for progression of chronic pancreatitis, for progression of fibrosis. So patients need to understand that they have to stop smoking and alcohol, which may help in reducing pain relapses, improve quality of life, and reduce the disease progression. The management of pain per se, we follow the same WHO analgesic ladder, and there is a updated version of it where a fourth ladder is also there, which includes intervention. And now the new ladder says that it may be a upside or downside. You don't need to be strict regarding the management of pain, that you have to progress from NSAIDs, paracetamol, opioids and all. Patient pain relief is very important, and for that you may proceed from top-down approach as well. So let's divide the talk in two aspects. First we'll discuss about exocrine insufficiency, and then we'll discuss about what is the role of pharmacotherapy beyond analgesics in control of pain. So the first is that when you are talking of pain in chronic pancreatitis, as I told, there are multiple mechanisms, and one of the main problem what occurs in chronic pancreatitis is that there is a lot of oxidative stress and generation of reactive oxygen species, and there you get the role of antioxidants. And the main component of these antioxidants is very high dose of methionine, which is about 1.6 to 2.8 grams per day of methionine, which is important in these patients. The best trial till date is from AIMS group and published in one of the highest impact factor journals, that pain relief in antioxidants is achieved in 32%. Means no endotherapy, no surgical therapy, just antioxidants. You expect a pain relief of 32% when you use this antioxidant for about 6 months. It's very important. There are many antioxidant preparations available in the market. So just a practical tip, that just see the methionine content of that antioxidant. If it is not 600 milligrams, it means this is not the antioxidant that you have to use. You have to see there are two types available. One is double strength, where the antioxidant methionine content is 1100, and one where the methionine content is 600 milligrams. So 600 milligram at least thrice a day you have to use. If you are using the double strength, twice a day you have to use. Now coming to the second aspect of this therapy, this is neuromodulator. We have discussed antioxidants. There is a lot of debate about the neuropathic component of pain in patients with chronic pancreatitis, and there is the mechanism being there is hypertrophy of nerves, there is allodynia, hyperalgesia and all. So for these, neuromodulators are very good. And this is one of the very good trials which suggests that if you give pregabalin, which is used for neuropathic pain for 3 weeks, and as a step-up doses, the chances of getting relief is 36%. So it's very important that these are simple drugs. And another important point that you have to remember, it is not gabapentin, it's pregabalin that we have to use. Pregabalin is more potent. Pregabalin has both peripheral and central actions, and the bioavailability of pregabalin is much more than gabapentin. So it's pregabalin that you have to use and not gabapentin. Now coming to, we have seen that antioxidants like which contain high dose methionine and pregabalin both are effective. So why not use a combination of both of these? So this was a trial from our group. This was a randomized trial where we gave these to patients who underwent endotherapy but still had pain. And you can see that the pain relief was much more, it was close to 50% in these patients as compared to placebo, where it was 27%. So this means that a combination can also be used in patients who have undergone some sort of therapy like surgery or endotherapy, but still they continue to have pain, because a lot of these patients have a neuropathic component of pain. The same trial was repeated by the Jitner Pondicherry. Both the trials are from India, and the results were the same, that if you give the combination of antioxidants and pregabalin, complete pain resolution can be achieved in as high as 58% patients. Now coming to last aspect of our pharmacotherapy, that is uncoated enzymes, which is used for pain. It's very important to remember that we used coated enzymes for exocrine insufficiency and we use uncoated enzymes for pain. And the main funda how it improves is that there is a feedback inhibition mechanism. For example, if you are taking food, what it does is it gives a signal, there is very high dose of release of CCK, which tells the pancreas to secrete juice. Now in a healthy pancreas this is okay, but when you have stricture stones, this leads to increased intraductal pressure. For this reason, when you give this uncoated enzymes which release a lot of protease, and this protease tells that there is enough enzymes, the CCK release does not occur, and finally the pancreas is not stimulated. So this is one mechanism why uncoated enzymes have been used for relief of pain. There are two very old but very good trials which have suggested that pain reduction can occur when you are using uncoated enzyme preparations in patients with chronic pancreatitis. So what are the patient groups where you should use uncoated preparations? Females with idiopathic pancreatitis, this is what we know from these previous trials. Those who have normal fecal fat excretion, those who don't have frank steatorrhea. Suppose if the pancreas is completely atrophic, there is no parenchyma left, so there is no benefit of using uncoated enzymes because this is already the pancreatic secretion is at its minimum, so these enzymes won't result in any further decrease in enzymatic secretion. What is the dose? There is only one brand which is available in Indian market, but you have to remember that the dose is very high when you are using uncoated enzymes for prevention of pain or treatment of pain. And you may have to use 3 to 4 tablets 3 to 4 times a day. So this is something which is very important to remember, that in low dose they are not effective at all. Now coming to exocrine insufficiency per se, there are coated preparations where lipase content is very important. So uncoated, you are more worried for proteases. Coated, which you are using for exocrine insufficiency, coated preparations are important. So no test is required for pancreatic exocrine insufficiency. This question often comes to now, how do I know that this patient is having exocrine insufficiency or not? If the patient is having typical symptoms, if there is improvement with replacement therapy, and in a patient who has dilated pancreatic duct with calculi, don't do any test. You can simply give enzyme replacement therapy. You don't require any test. In doubtful cases or where the diagnosis of chronic pancreatitis itself is questionable or there are minimal changes, in those cases you can use fecal elastase to tell whether this patient is having chronic pancreatitis or not. But remember that as high as 10% of cases, they have falsely negative fecal elastase. So clinical symptoms and your clinical judgment is very important. So what is the maths of PERT? How do you decide the dose of PERT? So this is basically, you have to give 5% of the normal enzymatic secretion which occurs postprandially. So this occurs 3,000 to 6,000 units per minute of enzymes are secreted for at least 4 hours once you take meals. So you just calculate 5% of that and it comes to 36,000 to 72,000. So this is what is how you calculate the dose of pancreatic enzymes when you give this to patient. Some practical tips about how to use pancreatic enzyme replacement therapy. When should you use it? Before meals, during meals, or after meals? I think all things they give comparable normalization of fat digestion. You can see that 100% normalization never occurs no matter how much dose you use. If you are a slow eater, you can finish your meals in more than 20 minutes. I think you should take half of the dose during the start of the meal and half of the dose in the mid of the meal. In patients who have undergone surgery, for example, patient has undergone some pancreatic dissection or gastrectomy, you may require higher doses and you need to open the capsules before you finally use pancreatic enzymes. Why fat should not be avoided in diet? This is a common misconception that patients should be on low fat diet. Fat is very important so that lipase can survive. We know that substrate is important so that enzyme can survive. If you consume a low fat diet, most of the lipase gets destroyed. The lipase activity is minimum in jejunum and ileum. So you should take a normal fat diet. You should not take a very high fiber diet because this is again detrimental for the survival of lipase. So this is the reason why fat should not be avoided in the diet of a patient with chronic pancreatitis. Now this is a very complex question. Which brand? Does it matter? Which brand do you use? Fortunately, all the brands have adequate particle size that is less than 2 mm. So less than 2 mm particle size is recommended in patients because this is the adequate size and this is the size which mixes with diet adequately. And they should release at a pH more than 5.5, and this is very important. So fortunately, all the Indian brands, they have less than 2 mm particle size. But what about other things? So you have to remember that not all the enzyme supplements or not all the pancreatic enzymes have similar activity. So this is one article. I'm not going to go into the detail because this may be a very controversial thing. But then you have to remember that different enzyme supplements, they have a different activity in duodenum, so you have to choose your enzyme replacement therapy very wisely. Coming to, there has been a lot of debate, so I just kept 2 slides there, that which patient endotherapy, which patient surgery and what to do. So there was a mixed opinion and finally we could agree that both are complementary. I agree with that, but one thing you have to remember that if the patient with chronic pancreatitis with multiple stones comes to you and if the patient does not have pain, no therapy is required. No intervention, no endoscopic intervention or surgical intervention is not required at all. Endoscopic intervention or surgical intervention is not indicated only for endocrine or exocrine insufficiency. It's indicated only if the patient is having pain. These 3 pictures, just remember, these are the patients I will send for surgery, and these are the candidates which I will send for surgery, who don't respond to endotherapy, who have diffuse stone burden, stones with stricture, head mass and duodenal obstruction. So this is my concluding slide, that one size does not fit all. I mean, you have to take each patient separately. You cannot apply the same argument for all the patients. So this is a gross problem. Those patients who have wiring problems, nerve problems, use neuromodulators, pregabalin, tricyclic antidepressants and all. Those who have a plumbing problem, means intraductal hypertension, go straight away for endotherapy or surgery. But remember that whenever you decide whichever treatment you have to give, early surgery gives better response than late surgery. So if you give endotherapy or medical therapy to these patients and these patients are not responding, don't keep on pushing for the same approach, because then surgery will also not give optimal response. So early surgery, you can give this try for 1 year, 2 years, but not more than that. Finally, if the patient is not getting relief, just go for surgery. So with that, this is my final chart. This is how we manage the patients in our hospital. This is algorithm provided by our group, and this is how we manage patients, combining all the approaches together: antioxidants, pregabalin, endoscopic therapy or surgical therapy. Thank you.
Thank you, Dr. Zahir, for the nice and lucid talk, how to manage the pain in acute pancreatitis. Our next speaker.
Thank you, sir. And next topic is state-of-art lecture, pancreatic transplant. For this, I will request Dr. Hardik Kotecha, sir, as a chairperson. And the speaker will be invited by the chairpersons.
For the next lecture on pancreatic transplant, present and future ahead, I would like to invite Dr. Saeed Jamal Rizvi, consultant urologist at IKDRC.
Okay, doesn't matter. Okay, good afternoon. It's a pleasure to be here, and I'd like to thank Dr. Yogesh Harwani and the scientific committee of the 4th Advanced Gastro Summit for inviting me to talk about pancreas transplant, something of which we've made a beginning and I believe has a lot of growth potential in our country. Now, we all know that diabetic kidney disease is the most common cause of CKD worldwide, occurring up to 1/3 of diabetics. India is one of the diabetic capitals of the world. We have about 74 million diabetics, 95% of who are type 2, yet we still have about 200,000 type 1 diabetics, which is the highest in the world. Although improvements are occurring rapidly in the management of blood sugar, however, they have the limitations, and blood glucose control is imperfect, leading to hypoglycemia and the complications of diabetes. Therefore, a more physiological approach is beta cell replacement, of which pancreas transplant and islet transplant are the options. Now, let's just compare these two. Pancreas transplant has been a clinical procedure for the last 60 years. It gives the best improved long-term patient survival versus a kidney transplant alone. Long-term insulin independence is up to 75% in 10 years, so often it's practically a cure for type 1 diabetes. There's a much reduced risk of major acute cardiovascular events, which is a major cause of death in these diabetics. And there's an improved quality of life. This must be balanced against the costs, which are lifetime immunosuppression, an increased risk of death due to surgical complications, including bleeding, leaks, and at 5 to 8% graft failure rate. Islet transplant is not available yet in India. It's still considered to be a research tool in the US, although it's clinically available in Canada and Europe. Basically, it's a benefit for less cost approach. It's less invasive. However, the long-term graft function is less than intact pancreas. There is an improved quality of life. You can see that insulin independence can be as low as 50% at 2 years. Compare this to 75% at 10 years. You need two or four donors. This means there's a lot of foreign antigens going in. This leads to sensitization. And it's expensive and needs long-time immune suppression. So you can see that a pancreas transplant, if successful, is gives much better results. Now, what is the rationale of a pancreas kidney transplant? The transplantation of a vascularized pancreas is the only method available for long-term normoglycemia in a type 1 diabetic. There's no burden of immunosuppression because the patient is already getting immunosuppression for the renal allograft. It's a life-enhancing operation, it's a life-extending operation, and this must be balanced against the complication rates. So some of you may be unfamiliar, so I'm just going to bring you up to the three types of pancreas transplant. Worldwide, 85% is a simultaneous pancreas and kidney transplant. Typically, this would be offered to a type 1 diabetic with end-stage renal disease who does not have a living donor. The advantages are that in a single operation, you give both dialysis independence and glycemic control. And immunologically, it's simpler because both the organs are coming from the same donor, and rejection is expected to be concordant in these two. However, there's a big magnitude of surgery, and your waiting time is likely to be longer. In India, we have largely a living program, although our deceased donor is increasing every day. 15% are a pancreas after kidney. So typically, if you had to have a patient who needed a pancreas and kidney who came with a living donor, you transplant the living donor kidney. This would give them prompt dialysis independence. Then you'd put them on the deceased donor waiting list and give them a pancreas when available. So therefore, you stagger the surgical stress. This also adds to the donor pool because you've added one living kidney to the donor pool, and this is important in the bigger picture of thing, not to that particular patient. And so it's appropriate for a country like ours where we have a lot of living donors. However, the renal outcomes are poorer than an SPK. And a pancreas transplant alone is rarely performed. It's the limited indications, very brittle diabetes, frequent episodes of ketoacidosis, and typically hypoglycemia unawareness. It gives good glycemic control and reduction of complications. However, this can lead to possible deterioration of the native kidneys due to CNI toxicity and other adverse events. Now, this chart actually summarizes justifies doing a pancreas kidney transplant. This is the survival of a type 1 diabetic with end-stage renal disease on dialysis. It's dismal. Half of them will be dead in about 3 years and about 70% at 5 years. If you do a deceased donor kidney transplant, survival is better, but still not very good. It's even better with a living kidney transplantation. But look here. If you put in a pancreas and a kidney transplant, the survival is, especially after 5 years, these lines diverge very dramatically. And you can see that at 20 years, a pancreas kidney transplant has by far the best survival advantage. Also, this is the survival of the kidney allograft with and without a functioning pancreas. You can see that if the pancreas is functioning, the survival is much better than either a kidney transplant alone or a pancreas kidney transplant in which the pancreas allograft was lost. Also, there's significant waitlist mortality. This just justifies as time goes by, there's a high mortality among type 1 diabetics with end-stage renal disease, and this also justifies doing the pancreas and kidney transplant. The results have been getting better and better, so you can see that now patient survival is in excess of 90% in all three categories of pancreas transplant. Similarly, organ survival is excellent, and it's about 90% for simultaneous pancreas kidney transplant, both for the renal and the pancreatic allograft, and it's a little inferior for pancreas after kidney, but it's still significantly improved. As you can see, this is the survival by era, and in every 5-year block from about the mid-60s to now, results have been improving. So although pancreas transplant has a bad reputation as being high complication, these are getting better as time goes by. Immunologic graft loss also happens as in any transplantation, but it's much better for simultaneous pancreas and kidney transplant. And it's the highest in pancreas transplant alone because of difficulties in monitoring rejection. When you do a pancreas and kidney transplant, the kidney acts as a surrogate marker, and rising creatinine gives you an early warning of rejection. A look at worldwide temporal trends. Pancreas transplants. Pancreas transplant peaked in the US at about 2005, and it's been declining since then for various reasons, partly increased regulatory oversight. However, in the rest of the world, it's a bit on an upward trend. India is a late entrant, but I think that as time goes by, there should be a similar growth pattern in our country too. The decline in pancreas transplant worldwide has mostly been pancreas after kidney. SPKs have been fairly steady over the last several decades. Now, does pancreas transplant improve diabetic complications? The answer is mixed. It's yes and no. If you look at a diabetic nephropathy, there's improvement in proteinuria, and the histopathology of patients who have a pancreas transplant in addition to kidney transplant are better at 10 years than those with a kidney transplant alone. Cardiovascular complications, which are the main cause of death in these patients, are significantly less with a pancreas and kidney transplant. So there's significantly less cardiovascular related deaths at a follow-up of about 8 years. There's better ejection fraction in patients who have a functioning pancreas allograft, and there's a significantly lower incidence of MI, strokes, and amputations in type 1 diabetics who have a functioning pancreas allograft as compared to those without. Similarly, diabetic neuropathy, there is some benefit. And diabetic retinopathy, again, it's a mixed picture, but early changes are reversible. Established changes will not reverse, and it takes about 4 years of normal glycemia to improve retinopathy. Another question that comes up is pancreas transplant in type 2 diabetes. The benefits are very crystal clear in type 1. In type 2, it's a little more controversial. However, worldwide, as experience improves and results improve, the numbers of transplants being done in type 2s are more. And those, it's indicated in those type 2 diabetics who are not overweight, who have C-peptide secretion but are insulin dependent, and who have diabetic complications. And the results are now similar to type 1. When it comes to selecting recipients, we typically select type 1 diabetics who are C-peptide negative, who are non-obese. Their workup is the same as for any transplant, except there's a lot of focus on cardiovascular disease, and perfusion scans, stress tests, and angiographies are done. If they have a cardiovascular disease which is not correctable, that would rule them out from a pancreas transplant. Coming to the selection of the deceased donor, you want the most pristine organs that you can get for pancreas transplant to reduce the complications. So the typical profile would be a young individual under the age of 40, non-obese, who has a traumatic brain injury as the cause of death, because this rules out other comorbidities like diabetes and hypertension. However, especially in Europe and the UK, they're applying expanded criteria where they take donors up to the age of 60 with non-traumatic causes of death, and even donation after cardiac death. At IKDRC, we've had a deceased donor program since the year 2000. Currently, we do about 60 to 70 donations per year, giving us about 100 kidneys and 50 to 60 livers. Because we realized that we were wasting pancreases. I went to the Oxford transplant program, which was the busiest program in the world in 2012. We did 2 cases when I came back. Both were unsuccessful due to complications, and our program kind of lapsed. And this is a fairly common story in pancreas programs around the world. We revived our program in 2017, and since then we've done 15 pancreas transplants, out of which 10 have been simultaneous pancreas kidney and 5 have been pancreas after kidney. Among our SPKs, we've had 2 mortalities. However, among the other patients, the survival has been 100%, and of the 8 surviving patients, 7 are insulin-free. In the pancreas after kidney, there's been one mortality and 1 graft loss. Our mean recipient age is 34, so you can see it's a young cohort of patients, most of them been diabetic for several decades. We've only been doing type 1, so they all have very low C-peptide levels. The donors have also all been young with a mean age of about 20. Majority of them had a head injury. This should be cold ischemia time has been about 11 hours, and the operative time for SPK is about 7 hours, and for pancreas after kidney is 4 hours. We've had our share of complications, including explorations for hemoperitoneum, intra-abdominal sepsis, bleeding, and prolonged ileus. Mortalities, some of them have been medical because of immunosuppression, some have been due to intra-abdominal sepsis. 2 graft losses, one because of chronic thrombus and one because of acute venous thrombosis. And at a mean follow-up of 2.4 years, we have a 80% patient survival, a death-censored pancreas survival of 75%, and 100% kidney allograft survival. So our challenges are that expertise is limited. There has been hand-holding by our mentors, but again, it's not the same thing as having a mentor on hand. Thank you. It's a small team. There's a high risk of complication, and this deters many people from referring patients. We have small donor and recipient pools, prolonged ischemia times, and suboptimal donor maintenance, which is actually plagues a lot of transplant programs around the country, and this needs systemic measures to improve. And as you know, you have NATO and SOTO, and the picture is getting better. Again, because time is limited, I'll skip all the surgical aspects. This is just a few pictures of the benching of the pancreas, which is a very important aspect. Typically, this shows for surgeons in the audience, the pancreas has two vascular inlets. One is a splenic artery and one is a superior mesenteric artery. And to make revascularizing them simpler, we take a Y graft of the iliac vein, anastomose, one to the splenic and one to the superior mesenteric artery, so they can both be revascularized with a single arterial anastomosis on the recipient. And this is the allograft ready to reimplant. This is the bed in preparation for implantation. And there are two ways of implanting the pancreas allograft, head up and head down. Initially, it used to be with the head down, and the C loop of the duodenum, which is attached to the head of the pancreas, would be drained into the bladder. Where this is simpler and safer, it has severe side effects because of bicarbonate loss. Now there's typically an enteroenterostomy with a jejunal loop. Immunosuppression is the same as for any kidney transplant. The pancreas allograft is monitored by creatinine, amylase, and lipase, which can suggest pancreatitis or rejection, blood sugar, and pancreatic allograft Doppler. Now, the complications are much dreaded, and there are 5 big complications which often result in graft loss. These are bleeding, graft thrombosis, pancreatitis, infection, and enteric leaks. And briefly, graft thrombosis is because of the sluggish blood flow of the pancreas. Do I have a minute? Or right? It could be technical, but typically it's because of the low flow state. And to compensate for this, we anticoagulate fairly aggressively, and this can lead to the problem of intra-abdominal bleeding, which can lead to coagulopathy. And this may be technical due to vascular leaks, or maybe due to over immunosuppression, due to over anticoagulation. And it can be managed either by correction of the coagulopathic state or by surgical intervention. Graft pancreatitis is fairly universal. There's physiological pancreatitis which occurs in 100%, but it's transient and self-limiting. Early graft pancreatitis can be a devastating complication, lead to graft loss, and late can usually does not lead to graft loss. Risk factors for early post-transplant pancreatitis include elderly donors, suboptimal retrieval techniques, and the treatment can be conservative or exploration, necrosectomy, or explantation. And this is an example of a pancreatic allograft which was explanted due to necrotizing pancreatitis. So the lessons we learned are that donor selection is paramount, cold ischemia time should be limited, you should train multiple team members and have redundancy, and there should be meticulous retrieval and bench surgery. The current status in India is pancreatic transplant is still in its infancy. 5 or 6 centers are actively doing it, the most busy of which is PGI Chandigarh. We don't have an Indian pancreas transplant registry, but about less than 200 have been done, probably till date. However, there's a trend, more and more centers are adopting it. And the limitations are that there are no standard donor maintenance protocols which hinders the retrieval of good allografts, the limited reference for endocrinology, and limited awareness in the medical fraternity overall. So future directions, there's a great opportunity for growth in India, and India needs pancreas transplant. There should be greater coordination between the transplant community and endocrinologists who manage these patients, strengthening of trained manpower, and standardization of protocols. Research in the future would tend towards steroid and CNI sparing. Islet transplantation, better insulin delivery systems, and bionic pancreases are all on the horizon, and they'll probably change the picture over the coming few years. So I'd like to say that pancreas transplant is feasible in India in a public sector hospital. There's better survival and quality of life in selected diabetic patients. Increasing the number, I believe, is the need of the hour in India. Donor numbers are going up across the country, although they're still low compared to the West, and this is an opportunity for expanding this program. And there should be institutional priority and allocation of human resources towards team creation. Thank you.
Dr. Jamil, nice lecture. And what would be the cost of this pancreatic transplant in IKDRC?
Right, sir. So at our institute, we give an estimate of about 7 lakhs of rupees for a pancreas and kidney transplant. So both organs, including everything, including the workup, the surgery, and the post-operative stay, and a month of immunosuppression. It would certainly be much higher in the corporate sector.
Okay. Thank you. Good, very nice lecture. And I was first to know that we are doing pancreatic transplant in Ahmedabad. So it is a good thing. Thank you for the lecture.
Thank you, sir.
Thank you, sir. Next topic is post-ERCP pancreatitis risk factor prevention and management. For that, I will request Dr. Anand Patel, sir, to come on the stage as a chairperson. The speaker will be invited by the chairperson.
I would like to invite Dr. Vikas Singla. He is a consultant gastroenterologist at Max Hospital, New Delhi, and will be going to speak on post-ERCP pancreatitis, risk factor, prevention and management.
A very good afternoon to all of you. At the outset, I am thankful to Dr. Yogesh for the kind invitation. So I will start with a very interesting story. So we can see the Roger Federer on the left side and the Noah on the right side. So they are discussing a very interesting incident which happened with the Federer. So after the retirement, Federer went to UK for the opinion regarding his right knee. And once the opinion finished, he had 2 hours. He thought that he will go to Wimbledon and have some tea. So there he met a security guard, a young innocent lady, and he told her that he is Federer and he is a member of Wimbledon and he want to be inside. The lady wanted the membership card. Unfortunately, he was not carrying the card, and he mentioned that he just mentioned that I have won the Wimbledon 8 times. So by virtue of that, he becomes a member, and can he be allowed inside? The lady says, I need the membership card. Without that, you cannot be allowed inside. And all through that, he was very polite, very humble, and without raising his voice, he went to other side. He asked, where is the gate to enter inside? And she mentioned, it's on the other side. And Federer went to other side. Luckily, one security guard identified Federer, and he had a selfie with Federer. Then Federer asked him, can I get inside? Then he called the chairman of Wimbledon, and then he could get inside. Then they had a tea. That shows the humble quality of this man, who is the greatest tennis player ever on the earth. And I think that quality should be imbibed by any endoscopist who is doing the ERCP. Because whatever experience we may have, there are certain complications of ERCP. Dr. Puri will agree that how many ERCPs we may have done, there is always a risk of 4 main complications: pancreatitis, perforation, bleeding, and cholangitis. So let's see how this complication occur. So this is the duodenum, and we can see on the duodenum there are 2 ducts opening together. One is the pancreatic duct, and that's the bile duct. So they are joining together and opening at the ampulla. Unfortunately, when we do the ERCP, we can see only one opening. You can see, so there are steps of ERCP. So there is only one opening, and with the certain maneuvering, we have to give a direction to the cannula. So sometimes the direction may not be perfect. So we just make a guess that wire will go inside the bile duct, but sometimes the wire can go in other direction, inside the pancreatic duct. So once the wire goes in other direction, there can be a complication of pancreatitis. Then we cut the papilla. If we cut beyond a certain limit, the duodenal muscle and the ampullary muscle separate, and there can be perforation. And the
and sometimes there is a rich vascular plexus there. If that plexus is injured, there can be bleeding. So three complications, pancreatitis, bleeding and perforation can occur during the ERCP. We will focus on the post-ERCP pancreatitis. So what's the definition? So it's a new or the worsening of pain after the procedure, and the amylase or lipase should be 3 times of the normal value at more than 24 hours after the ERCP, and it should requirement of admission after the procedure. So 3 things: pain, raised amylase lipase, and prolonged admission. So how we assess the severity? There are 2 criteria. One is the consensus paper-based guidelines, which show depending on the duration of admission. Admission less than 3 days, it's mild; 4 to 10 days, it's a moderate; and more than 10 days, it's a severe pancreatitis. And recently, we are using the Atlanta classification that we already discussed to define the severity. If there is organ failure, it becomes severe. If there is transient organ failure or local complication in the form of necrosis or the fluid collection, it becomes moderate. Absence of both these, it's a mild pancreatitis. So this is the local complication. In interstitial pancreatitis, there is no necrosis. When we give the contrast, we can see it's a white pancreas. There is no necrosis. So it's an interstitial edematous pancreatitis, and there can be fluid collection which will resolve spontaneously. On the other hand, on the right side, we can see after giving the contrast injection, we cannot see the pancreas. It means it's a necrosed pancreas, and the collection will be acute necrotic collection. They are likely to have more complication in the form of fever and the organ failure. So if you see the post-ERCP pancreatitis compared to other causes of acute pancreatitis, they are milder. Only 5 to 10% they will have severe pancreatitis, and few patients may develop pancreatic necrosis, which is around 18%. This is AIMS data. 3% of patients can develop organ failure, and mortality can be in less than 2%, which is lesser as compared to pancreatitis due to gallstone or the alcohol. So let's understand what's the pathophysiology of acute pancreatitis. So there can be edema to the pancreatic sphincter, there can be local injury to the pancreatic sphincter, which can block the excretion of pancreatic secretion. And second, when we inject the contrast, that can go inside the pancreatic duct, and due to high pressure, there can be injury to the pancreatic parenchyma. So this is called hydrostatic injury. Then there can be chemical injury due to the contrast agent. Then there can be allergic reaction to the contrast, and sometimes we use the guide wire. Guide wire can go inside the pancreatic duct, that can injure the pancreatic duct, again leading to pancreatitis. And sometimes when we use the electrocautery, there can be delayed thermal injury leading to edema of pancreatic sphincter, again leading to transient blockage of secretion, leading to acute pancreatitis. So who is to be blamed for acute pancreatitis? There are 3 factors: patient-related factor, endoscopist factor, and the procedure-related factors. So we can see young female with the non-dilated duct and the normal bilirubin. If you do ERCP in these patients, they are at the highest risk of pancreatitis. But let's see, these patients doesn't require ERCP also. They have normal CBD, they have normal bilirubin. So these are not the candidate for the ERCP. That means most cases of post-ERCP pancreatitis are avoidable. If the patient has past history of pancreatitis, then also they are at risk of post-ERCP pancreatitis. A peculiar condition, sphincter of Oddi dysfunction, presenting recurrent pain abdomen with the dilated CBD with raised liver enzymes but without stone or tumor. It's a SOD. Again, this is a condition for high risk of pancreatitis. Then there are endoscopist related factors. It has been seen that endoscopist who has a lesser experience, they have high chance of post-ERCP pancreatitis. This is likely due to difficulty in cannulation of CBD, longer procedure time. The longer the time we spend at the cannulating the CBD, longer will be the injury to the pancreatic duct or pancreatic sphincter, the higher will be the risk of acute pancreatitis. Or if there is an accidental cannulation or the contrast injection in the pancreatic duct, there will be a risk of acute pancreatitis. And it's a very interesting July effect. In the US, they recruit the new fellows during the July period, and then they get trained into the ERCP, and it has been seen that during those months the risk of pancreatitis increases. So that means that if the trainees are doing more ERCP, there can be a higher risk of acute pancreatitis. Then there are procedure related factors. If it's a difficult cannulation, multiple pancreatic duct cannulation, or the contrast injection inside the pancreatic duct, or if you are using a biliary balloon for the dilatation, sometimes patient has coagulopathy or have large stones. In those cases, we use the balloon dilatation to dilate the papilla, and through the larger opening, we remove the stone. That again a risk factor for the acute pancreatitis.
And then we divide papilla in the 4 types. If it's a small papilla, there is an increased risk of pancreatitis. You can see in a smaller papilla, there is a risk of around 20% for the acute pancreatitis. So ESG has summarized the various risk factors. There are definite risk factor and there is a likely risk factor. So if there is a 1 definite or 2 likely risk factor, they categorize it as a high risk for the post-ERCP pancreatitis. We can see here, female, younger age, non-dilated bile duct, previous history of pancreatitis, suspicion of SOD, or difficult cannulation, or the PD cannulation more than once. These are all risk factors for the acute pancreatitis. So how can we avoid the post-ERCP pancreatitis? First is by avoiding the unnecessary ERCPs, and so that most common indication is the bile duct stone. So we should always confirm that there is a stone in the bile duct, only then one should go ahead with the ERCP, and EUS may be slightly better than the MRCP for detection of a bile duct stone, and single session EUS or ERCP can be performed. It can save you the time also. And if the patient has resectable malignancy like pancreatic cancer or cholangiocarcinoma, they can be directly sent for the surgery without doing the ERCP. So this is the most common scenario. A middle-aged female comes to us with a gallbladder stone and bilirubin is normal, SGOTPD slightly elevated and slightly elevation of alkaline phosphatase and gamma GT. Ultrasound showing 8 mm CBD, but the distal part cannot be seen because of duodenal air. So what should be the next step? Should we go for the ERCP or should we work up more in this patient? Anybody? So for these we have the stratification criteria according to ASG criteria and the ESG criteria. So if the patient has cholangitis or a visible stone on CBD, in the CBD on ultrasound, they are high likelihood of CBD stone. They can be directly sent for the ERCP. Then there is an intermediate likelihood. They have abnormal LFT, age more than 55, dilated CBD but without stone. It's an intermediate. So these patients have low chance of CBD stone. We should work up further. Like this patient, we should do either US or MRCP. If there is a stone, we should do ERCP. No stone, directly sent for surgery. Low likelihood, normal LFT, normal CBD on ultrasound. No need for doing the ERCP. No need for further workup, directly go for surgery. Though this patient had intermediate likelihood of CBD stone, so this patient should undergo either US or MRCP. Depending on that, we should treat further. So patient who had high likelihood criteria, there will be 90% chance of getting the stone in CBD. They can go directly for the ERCP. In intermediate, there is 10% chance of having CBD stone. So we should work up further. Low likelihood, unlikely to have CBD stone, so we should directly send for the surgery. So how can we avoid the post-ERCP pancreatitis? First is the medical prophylaxis. So the rectal indomethacin or diclofenac are the most commonly used agent to prevent the post-ERCP pancreatitis. So 100 mg suppository is given per rectal route prior to starting the ERCP. It can prevent the post-ERCP pancreatitis. The patient who had reaction to the NSAIDs previously, it's a contraindication. Pregnancy after 30 weeks, again it's a contraindication because there can be premature closure of ductus arteriosus. If there is a contraindication to NSAIDs, one can use the IV hydration. For that, ringonactate is the best agent. 3 ml per kg per hour should be started prior to the starting ERCP. During ERCP, bolus is given. Then again the infusion is continued for the next 8 hours. And in patient with high risk of fluid overload like CKD and CHF, it should be avoided. If both NSAIDs and the fluid are contraindicated, one can use sublingual subnitrate 5 mg before starting the ERCP. And there is conflicting data regarding topical epinephrine or the various protease inhibitor. They are unlikely to have benefit in this scenario to prevent the post-ERCP pancreatitis. And then there are procedure related factors. So one should try to shorten the duration of the procedure. That will reduce the risk of pancreatitis. If there is a difficult cannulation, one should try the alternate techniques. Or if there is a wire is going inside the pancreatic duct, one can use the pancreatic stent, and the smaller balloon should not be used for the dilatation. With a smaller balloon, there is a high risk of post-ERCP pancreatitis. So what is the difficult cannulation? 5-5-2 rule. If after 5 minutes and 5 contacts with the ampulla or more than one time opacification of pancreatic duct, it's a difficult ERCP. So the next step can be the early pre-cut or the pancreatic double guide wire technique. In pre-cut, we cut the papilla from above downward. Normally, the papilla is cut from the inside out. First we enter the papilla and then cut the sphincter. In pre-cut, it's without cannulation, we are cutting from the outside to inside, and then we expose the biliary opening, and then we enter the bile duct. And study has shown that if we do the early pre-cut, it can reduce the risk of post-ERCP pancreatitis. If it's a difficult cannulation, one should do the early pre-cut. Just 2 more minutes. And another is the pancreatic guide wire technique. If wire is going inside the pancreatic duct, one can keep one wire inside. That will help us guiding the CBD. So with one wire inside, we are cannulating above and down the left side of this wire. So this will help in easier cannulation of the bile duct. And another is the transpancreatic sphincterotomy. So what we are doing, our knife is in pancreatic duct, but we are cutting towards the bile duct. That will open the bile duct and it can be cannulated. And after both the procedures, we should place a stent in the pancreatic duct. And regarding the balloon dilatation, sometimes we have to dilate the papilla, and it was seen that if we are using the small balloon, only 8 mm diameter, there can be high risk of post-ERCP pancreatitis. So it's better to use a larger balloon. If you use the balloon more than 12 mm, there is lesser risk of pancreatitis. So if you have to dilate the papilla, the larger balloon should be used. So how we diagnose? As I mentioned, the amygdala lipase should be more than 3 times of upper limit of normal. There should be pale epigastrium. Sometimes it can be confused with the post-ERCP perforation, so imaging should be done to rule out the perforation. And the mainstay of treatment during initial week is the IV fluid and the antibiotic. As we have done the biliary manipulation, antibiotic should be continued. And the rest of treatment is similar to other cases of acute pancreatitis that we have discussed during the last session. So to summarize, post-ERCP pancreatitis is a common but serious condition, and there are patient factors, endoscopist factor, and the procedure-related factors. To avoid the post-ERCP pancreatitis, one should avoid unnecessary procedures, and difficult cannulation is a predictor of post-ERCP pancreatitis. Early pre-cut can reduce the chance of pancreatitis, and if there is difficult cannulation, one can use double guide wire technique or the transpancreatic sphincterotomy technique. After this, PD stent should be placed inside the pancreatic duct to reduce the risk of pancreatitis. Rectal NSAID and IV hydration are effective in preventing the post-ERCP pancreatitis. And management is similar to other cases of acute pancreatitis. Thank you very much for your patient hearing.
Excellent presentation, Dr. Vikas. Thank you.
Thank you, sir, and thank you, chairpersons. Next, we have case-based panel discussion, pancreatic mass on USG abdomen. So I will request Dr. Rajesh Puri sir, Dr. Vikas Singla sir, Dr. Chelapati Rao sir, Dr. Chainveer Basha sir, and Dr. Devat Vaishnav sir as a panelist.
Good evening all. So we'll start this case, a typical scenario that's encountered not very commonly, but sometimes in your clinical practice. What if a patient comes with a pancreatic head mass on ultrasound? So the learning objectives of this case-based panel discussion is what is the differential diagnosis, what is all information that you should gather on ultrasound, what is the subsequent imaging that you should do, how to proceed in that case, and tissue diagnosis, do you need it in all, or you can avoid in some patients. So a 54-year-old gentleman who is a known diabetic comes to you with an epigastric dull pain for 6 to 8 weeks, has a history of recent yellowish discoloration of eyes and urine and some itching for last 1 week. You get an ultrasound done and you find a pancreatic head mass. So how to proceed? So this is not a quiz, this is all, we have an expert panel here. So I'll start with from the left with the most senior guy here, Dr. Rajesh Puri. Rajesh, what questions come to your mind when a patient comes to you with a report of an ultrasound which mentions that there is a mass in head of pancreas?
Yeah, can you show me the ultrasound which is shown in the first? So I think it's a very good ultrasound image has been taken. If you look at, there's a dilated common bile duct and there's a dilated intrahepatic ducts. And you can see a heteroechoic mass in the head of the pancreas with the vessels appears to be free or assembly is just abutting the mass. So this kind of ultrasound image you hardly see in your clinical practice because most of the time pancreas being a retroperitoneal structure is difficult to visualize and most of the report shows lower part of the CBD and pancreas is obscured by the gases. But yes, if patient has a surgical or the clinical scenario, typical surgical obstructive jaundice with the suspected head mass, and what would we like to see is, first you would like to see, like in this the mass is shown, otherwise you would like to probe is it a mass or stone. You want to confirm with the other modalities. If it is a mass, then it is a solid or cystic. It is a benign or malignant. You would like to know about the rest of the pancreas, the distal body and tail is atrophic or not, what is the status of the liver, is there is any metastasis, there is or not, and you would like to look for the ascites. So these are the important points which you would like to see with other imaging modality.
So next, I'll come to Dr. Vikas. A solid mass in pancreatic head, and you have a lot of differentials, lot of things. Pancreatic cancer is only one of the differentials. So just want to know, what are your top priorities, like what are the top most differential diagnosis of a pancreatic head mass in your opinion?
So it depends on the clinical scenario. If the patient is elderly patient coming with the obstructive jaundice, dilated MPD and dilated bile duct without any evidence of chronic pancreatitis on imaging, I will take it to be malignant. On the other hand, if there is no pain abdomen without ductal dilatation, incidental mass lesion, solid mass, it can be a neuroendocrine tumor. Young female, it can be a SPN also. And if the patient is alcoholic or having chronic pancreatitis, it can be a inflammatory mass lesion also. So I think these are the main differential diagnosis.
Exactly. So pancreatic head mass, it can be a neoplastic pancreatic ductal adenocarcinoma, as Dr. Vikas said, it can be an inflammatory mass. It all depends on clinical imaging, clinical history, and how does the imaging tell you about that? It may be an autoimmune pancreatitis, it may be a neuroendocrine tumor or several other tumors like acinic cell tumors. So coming to the history part of it, and I'll now go to our surgical colleague, that what are the red flag signs which point that something is wrong? Probably this is not a benign looking mass in a patient who comes to you with a mass in head of pancreas. There are some red flag signs that all the physicians or surgeons should know that that these point towards something is wrong.
Mostly when patient comes with de novo of obstructive jaundice, but as you said, 54-year-old male and diabetes mellitus, so I would like to ask first that how long diabetes, recent onset diabetes or recently worsening the diabetes, plus that USC picture that showed the pancreatic head mass. The chances of pancreatitis is also high. So patient may be previously treated as a mild pancreatitis, may have a history of pancreatitis. At the same time, alcohol and smoking, again to rule out not only chronic pancreatitis, but sometimes it help, maybe one of the reason for head mass. Recent change in the pain, recent change in the sugar, that is also one of the important things that already I accessed. Along with anorexia and weight loss, most of the time what happens that being a pancreas or retroperitoneal organs, vague symptoms, vague abdominal pain, sometimes even some towards unsigned process mass reach the CBD and obstructive jaundice will be late appearing sign, and just patient having anorexia and weight loss, and it's difficult to diagnose.
Exactly. So it's very important. We do have excellent imaging modalities now. We have very advanced modalities, but nothing replaces a good history and clinical examination in any patient. So this is, as you grow, as you become a gastroenterologist, cardiologist, you stop clinical because you have echo now, you don't do a good clinical examination. You are a gastroenterologist, so you all depend on imaging and CT, but it's very important that history has, very important. The reports can be wrong. Many times we have seen that the imaging tests or the reports which are being mentioned, they don't fit with the exact clinical picture, so history is very important. Now, I'll come back to Dr. Jahangir and say that we just have this information that there is a hypoechoic mass in head of pancreas. But ultrasound is a very excellent, very good imaging modality, and it can provide a lot of information regarding other details which can be useful while we diagnose this case or we plan further management. So what all information do you think that you can ask your radiologist friend that please give me this information as well, which will help me in clinching the diagnosis and plan further management?
Yeah. So ultrasound is a very commonly available and commonly performed investigation modality where you can pick any lesion, but being pancreas retroperitoneal, if something is picked up, so instead of that, easily we can see many other things, like whenever there is a suspected mass, you can look around the mass and the organ from which is arising, that is in this case pancreas, and also you can look for the liver, so where you can see for any possibility of metastasis. You can look for any lymph nodes, and you can look for any pancreas ascites. So this gives a rough idea about the extent of mass. When it comes to the specific pancreas, we can get a fair idea about the mass, whether it is a solid or cystic, whether it is inflammatory, if there is any inflammation ongoing is there, and you can look for any edema, rest of the pancreas, how is it, and also we can get an information about the pancreatic duct, underlying chronic calcific pancreatitis. So it gives many clues to proceed further.
Exactly. So ultrasound is being now considered, it's very underrated. A good ultrasound can give a lot of information, especially if the patient is not obese. So a good ultrasound can tell you all. It can also tell you about the relation of the mass with the vessels. It can pick up liver lesions and all, and you don't need to go for any higher investigation if you have a good ultrasound and it provides you with adequate information. Nowadays the trend is you find something on ultrasound and straight away the next imaging is do a CT, do a PET CT, do a MRI. But many times ultrasound alone can clinch the diagnosis, and that should be it in many scenarios. Now coming to further evaluation, and I'll like to ask again our senior gastroenterologist Dr. Rajesh Puri, what is the further evaluation, what are further investigations? You see a head mass on ultrasound, you know it's a hypoechoic syndrome. What are the biochemical evaluation that you would like to perform in this patient? What are the blood tests that you want to go ahead in this patient?
Yeah, so the investigation will be directed beside the routine investigation, like you are going for the CBC, liver function test, or the kidney function test for the further CT examination. Your investigation will be directed according to the etiology, what you have made on your clinical ground. Suppose you are suspecting an autoimmune mass in the head of the pancreas, and you might order the patient for IgG4 levels. But the commonly labeled tests are liver function test and CA19-9, which in my opinion may not be of a great value. But the most important test which is required is a liver function test and the kidney function test for the further CT examination you would like to do it.
Exactly. So these are the results of our patient. Patient, 54-year-old gentleman with pancreatic head mass. His HbA1c glycosylated hemoglobin means he's having uncontrolled diabetes. His bilirubin is 12.4. his creatine is 1.1, and CA99, the upper limit of normal is 37, and his value is 124.
I would like to tell one thing on this, can we make it on the previous slide? Like sugar control is important, but that is not going to guide you, does this patient is suffering from the malignancy or not.
Exactly.
Number second point, bilirubin has lot of importance because is it an operable or unoperable, you require a surgery, then you require a preoperative decompression or not. If the patient is unoperable, preoperative decompression. So bilirubin level is very important. Kidney again is very relevant point of view of chemotherapy as well as along with the doing the further investigation. CA19-9 I don't give a good, because this is a very common test and many of the physicians and even the surgical colleagues says the CA19-9 is 2000 and this patient has a pancreatic malignancy. That is not true. The CA19-9 may be falsely positive or falsely negative. It may be high with the patient of pancreatitis or obstructive jaundice or patient has cholangitis. We have seen CA19-9 up to the tune of 3000 in the patient was a cholangitis. The CA19-9 is not going to tell you that this patient has pancreatic adenocarcinoma or malignancy or not. That is very important. It has important role in the post-operative phase when the patient is post-Whipple state and the CA19-9 again started rising, then yes, it indicates that there is a somewhere the recurrence of disease is there. Yes, in I think some of the guidelines it has been written that the higher value of CA19-9 give idea about the pancreatic malignancy, but my understanding says that it has no role in diagnosis per se for the pancreatic malignancy.
Exactly. So CA99 is very commonly performed, but two things have to be remembered whenever you order for CA99, that false positive and negatives both are common, so it has very limited utility in diagnosing pancreatic malignancy. And the best way to perform CA99 is once you have performed biliary decompression if it is required. So once you have reduced the bilirubin levels, then you get the actual value of CA99. Before that, you may not get the accurate value of CA99. It does carry some prognostic significance, but diagnostic significance is limited for CA99. So coming to Dr. Vikas, what is the next imaging modality that you think this patient requires? You have some information on ultrasound, but you require more information. How do you decide between these imaging modalities, that which imaging modality should be performed in this patient?
So, in a patient with suspected biliary malignancy, it depends on the level of block. If the patient has a lower end block, CT scan is a good modality. In the patient with a higher block, you may opt for the MR angio with the MRCP. If you require biliary decompression, that may give you a roadmap. So this patient has a lower end CBD block, likely to have either ampullary, pancreatic or cholangiocarcinoma. So CT can give us a very good information regarding the resectability. So on CT scan, I would like to see peritoneum first and the omentum, liver and the para-aortic area. If I have para-aortic nodes or the liver as well or the peritoneal thickening, it's likely to be unresectable. Then I want to have a local staging. So I want to see the size of the lesion. Then I want to see the relationship between the tumor and SMA, SMV, portal vein and the celiac artery. So with that information we can further differentiate whether it's operable, inoperable or...
Exactly. So in a patient with pancreatic head mass, as Dr. Vikas said, the imaging modality of choice is pancreatic protocol CT along with CT chest. So the most recent NCCN guidelines published in 2022 mention that ideally you should do a pancreatic protocol CT along with CT chest. Now what is pancreatic protocol CT? It should be remembered that a simple CCT or contrast enhanced CT is not going to work. There is a definite protocol to do a pancreatic protocol CT, so that should be followed. This is one learning lesson for us. Now for example, how does CTL? CT gives you so much information that immediately you can decide whether this patient is with a mass is operable, inoperable or a lot of other information. So I'll come to our surgical colleague that suppose you get a CT image something like this, and what do you interpret with this image? You have a mass which has been outlined in purple color, and you have this vessels, you have celiac vessels visible, you have common hepatic artery visible. How do you decide for this patient? What are you going to do with this patient?
So after that USC picture, if I see, I was happy that patient will be operable, but then after seeing these CT images, I am horrified and maybe as a surgeon I am discouraged. because this entire celiac axis, both the axes are involved, almost entire, both the branches are also encased, fully encased, and probably this is not a case for upfront surgical candidates.
Exactly. So it's very important that even though if something looks operable on ultrasound, why next imaging modality is required? Because you need to know whether, even though there are no liver lesions and all, but there are other non-resectability criteria. Still you have a doubt whether the patient is having an inflammatory mass or it's a malignant mass. So Dr. Rajesh would like to ask you again, what is the role of advanced US modalities in deciding whether this is a inflammatory mass or this is a malignant mass? Can we do something more besides simple CT imaging or ultrasound imaging? Beyond that, do we have something?
Yeah, I think this is a common problem. Sometimes patient comes with a pancreatic head mass, and even if you have taken the biopsies and it is negative and you are not very sure are you dealing with the surgery or not, especially in inflammatory head mass, then the two modalities as it is shown in the slide, contrast enhanced endoscopic ultrasound. It is like a contrast enhanced ultrasound, percutaneous ultrasound imaging, where you give the contrast agent and what you see, the three things you can find out: a hypervascular lesion, hypovascular lesion, or mixed or isoechoic lesion. Hypo is related to the adenocarcinoma, hyper is related to the neuroendocrine tumor, and mixed echogenicity or ISO is related to inflammatory head mass. And same with the elastography, this is also started with the carcinoma breast. The harder the tissue, the blue will be the color, and that favors more towards a malignancy. And the other advantage of these two modality, you can target your FNA in an area which is blue in color or the area which is hypovascular, that may give the better yield of your FNAC or the true cut biopsy. So this is the two modality where you can find out.
So means we have now advanced imaging modalities which can help in, sometimes even biopsies are not inflammatory. If biopsy shows adenocarcinoma, means it's malignant. If it does not give you the diagnosis of adenocarcinoma, then you are still puzzled whether this is a benign or inflammatory mass. So EUS has definitely has some. This is just an interpretation of CT, how CT is interpreted. Just for physicians, I have simplified this slide, that what is resectable, what is borderline resectable, and what is unresectable. So if any of the major vessel is in contact with the tumor and the contact is less than 180 degree, it's borderline resectable. If it is more than 180, it's unresectable. So very simple funda. If you have to ask your radiologist that what is the exact degree of contact, if the CT does not mention it, you again have to talk to your radiologist that I want the exact degree of encasement. It does not, you cannot simply write that it's involving vessels. You have to give the exact degree of encasement so that I can decide whether I have to refer the patient to a gastro surgeon or I have to refer it to a gastrophysician for palliation of jaundice and all. So this is very important that the degree of involvement of vessels plays a major role in deciding whether these patients are resectable or unresectable. You can see that simple abutment means the patient can still be resected provided either you give a neoadjuvant therapy or you can reconstruct that vessel, but full encasement of SMA and celiac means that this patient is not going to benefit. So fortunately, this is our case. Coming back to our case, these were hypothetical scenarios who had a small mass. There is a 3 by 2 centimeter hypodense mass. There is no vascular involvement, no lymph node, no liver lesions. Mind you, this scenario is found very uncommonly. This is 5 to 10% of cases you find such a scenario. Majority of the cases are unresectable by the time they come to you. So coming to Dr. Jahangir, what next? What would you like to do with this patient? Now you have a mass. Do you want to take a tissue diagnosis to confirm the diagnosis? Do you want to go for biliary drainage, or you can send the patient straight away for surgery or neoadjuvant chemo? What are the options among these that you would like to do for your patient?
So we have a mass on the CT and we know the staging also, and it is operable. So we leave the decision of histopathology to the surgeon. If the surgeon asks for histopathology, we'll do, but there are guidelines that if there is a clear-cut mass, clinical setting is appropriate, even without FNA, we can proceed for surgery. But definitely when it is required chemotherapy, unresectable mass, then it's mandatory that we should have a tissue diagnosis. In a resectable mass, it is up to the surgeon station. But in routine practice, nowadays we are performing FNAs because even we are picking up, even surgeons also sending for FNA before going ahead for the surgery. So in general we are doing FNA, but it is up to the surgeon's decision.
So very important point made. First, that tissue acquisition, biopsy proof of malignancy is not required before surgical resection for clearly resectable lesions in head of pancreas. This is very clear. If the lesion is resectable, you should not delay. For example, you take a biopsy, a surgeon asks for a biopsy, your biopsy turns out to be negative, but it still looks a malignant mass, clinical scenario is perfect. Then a non-diagnostic biopsy should not delay surgical resection when the clinical suspicion for pancreatic cancer is high. You should not push or keep on repeating biopsies because you don't have a conclusive diagnosis there. This is very important. Clinical suspicion is good enough. And EUS FNA, as Dr. Jahangir said, is preferred to CT-guided FNA in patients with resectable disease for two reasons. One is better diagnostic yield for EUS-guided biopsies, and second is it's safer and potentially lower risk of peritoneal seeding. So whenever you have to go, your surgeon asks for a biopsy, it means it has to be EUS-guided FNAC unless. The other thing that is very important is that patients, unless they are in cholangitis, they don't need a routine preoperative biliary drainage. So the other option was, should you do a stenting in these patients? The bilirubin is 12.4. You don't require that, and we have enough evidence for that, that all patients who are jaundiced do not require routine preoperative biliary drainage. They can straight away be taken for surgery because surgery is good and safe enough. So this is just indication for pre-op biliary drainage. I think Dr. Rajesh can highlight on this, that in what clinical scenarios will you go ahead and do a biliary drainage in these patients before surgery?
So I think it's a good questions, and both for the gastroenterologist and the physician. Lower end CBD block and the hilar block both has a different cut value for the biliary drainage. For lower end, 10 or 15 different center uses different, which is acceptable. If patient is in cholangitis, and one more from our own center, from my center, it has shown that patient might not be febrile, but the counts are mildly elevated, like 12,000 with the liver enzymes, 2 to 3 times upper limit of the normal. They might have a low-grade cholangitis, and it is better to do a preoperative biliary drainage. But if it is not indicated, bilirubin is bland cholestasis, 12 bilirubin, normal liver enzyme, no need to do a preoperative biliary drainage because you are unnecessarily delaying the surgery, and many of the time ERCP has its own complications.
Sir,
So
what if the patient has pruritus? Bilirubin is less than
the
50.
patient will directly go for a surgery. The reason is that ERCP is not successful always. Suppose out of 100 patients, in the 7th patient you are not able to cannulate, or patient you will end up into a pancreatitis, or once you put a stent, patient straightforward go delay surgery for 3 to 4 weeks. So it is better if less than 10 or 15 bilirubin, depending upon the centers, you straightforward subject the patient for surgery who is resectable candidate rather than doing. And for hilar cholangiocarcinoma or hilar block, bilirubin level should be less than 3. In these cases, patient require a biliary drainage is mandatory either before surgery or before radiochemotherapy, and that is also preferable depending upon the type of block you are dealing.
Here can I make a point regarding the bilirubin value? Even if the bilirubin is more than 15 and patient is candidate for the surgery, no pruritus, no cholangitis, good function status, they can be, I think, sent for surgery irrespective of bilirubin value.
Yes, yes, and I completely agree with that. Different centers have different, what I would say, there are customs made. They are not science based. For example, in my center, somewhere between 15 and 20, the surgeon is a little skeptical about proceeding straight away with surgery. At some centers, although there is no evidence for it, at some centers it's like they operate at as high as 20 levels. But what I have seen in the routine clinical practices, there is no evidence that they should not operate above 15 or above 20. But then this is something which surgeons love to follow. So this is just an arbitrary cutoff. For example, the landmark NEGM trial which we have, they took a cutoff of 15. So we are just arbitrarily following a number. There is no strong evidence that is it 15, is it 20, is it 10 or is it 25, does it matter? I think in a fit candidate, even 20 does not matter. And in an unfit candidate, suppose the patient needs nutritional support and all, that is another indication if you want to improve the patient of his nutritional status. Some patients undergo routine pre-biliary drainage before he can be taken up for
In the larger scenario, bland cholestasis, it will depend upon your surgical colleague where he is comfortable. If you don't require, there is no need for the biliary drainage.
The surgeon should be confident.
Then yes, you should be. But if there is a cholangitis, then yes, it is mandatory to do the biliary drainage and preferably with a metal stent.
So that should be it. I think we have exceeded time. What are the take-home messages that pancreatic head mass, it's not always cancer. There are a few other differentials and that should be ruled out. A pancreatic protocol CT is the ideal imaging of choice, not PET CT. Mind it, PET CT is not routinely recommended in patients with pancreatic head masses, and CT is good enough. So that can save you some bucks. Role of CA99 is only for prognosis, recurrence and response to chemo. This is prediction and it's not beneficial in diagnosis. Surgery versus palliation, we have seen two cases, two CT images, that in which case can undergo surgery and which case is ideal for palliation, even without liver or lymph node mets. If you have vascular encasement, major vascular encasement, that patient is a candidate for palliation. Tissue diagnosis is not mandatory. This is very important that many times we get patients for tissue diagnosis. It's because we have a referral base, we do tissue diagnosis, but it's not always mandatory and it should not delay surgery. So surgical delay is not what we want in these patients, because these patients should be operated as soon as possible. Pre-biliary drainage is the last thing that we discussed. It's not mandatory. There are only few selected indications. So ideally the patients, fit patients, they should straight away undergo surgery without any ERCP, stenting and all those procedures. That's all from my side. Thank you.
Thank you, sir. Thank you, Chairperson. Next topic is palliation pediatric malignancy, role of endoscopies. For that, I will request Dr. Neeri Parkiwala, sir, Dr. Manoj Agrawal, sir, Dr. Ashish Solanki, sir, Dr. Nitin Singhal, sir, as a chairperson. The speaker will be invited by the chairperson.
So it is my pleasure and privilege to invite Dr. Professor Rajesh Puri to speak on palliation in pancreatic malignancy, the role of endoscopist. And we are all aware that as far as palliation in pancreatic malignancy is concerned, the role of surgeon continues to diminish all the time. And rightly so, because surgery itself is morbid. These are compromised patients. And I think endoscopy here has a great role to play in palliating and improving the quality of life in these patients. Dr. Rajesh Puri.
So, good evening, Chairman sir and dear friends. Thanks to Dr. Yogesh for giving this opportunity, and my job has been cleared by a surgical colleague by saying that the role of surgeon is very limited in the patient of pancreatic malignancy. So I'm going to talk what is the role of endoscopist and what are the conditions where as an endoscopist we can help the patient. So palliation of pancreatic malignancy, especially if patient has a jaundice or gastric outlet obstruction, the pain is a very important part of palliation, and the pancreatic tumor ablation, there are the few of the studies available. So endoscopy or the ERCP is the first line of treatment for the biliary drainage as well as for gastric outlet obstruction, but fail in around 3 to 10% of the cases. So this is an ERCP patient with a lower end CBD block. You can see this is the wire has gone into the CBD. Cholangiogram shows grossly dilated CBD with a non-dilated lower end, and you can do a biliary sphincterotomy and followed by preferably put the metal stent rather than putting the plastic stent. This is a common feeling that metal stents are costly and the plastic stents are not, but these patients again come with the blockage of the stent and they'll end up into a cholangitis, and like this patient earlier was on the plastic stent, you require antibiotics, you require a repeat ERCP, cost of treatment goes high. So it is preferably these patients require neoadjuvant chemotherapy, better to put the metal stent. So this is the fluoroscopy. We are doing the fluoroscopy cannulation of the bile duct, cholangiogram was taken, and then the metal stent was placed under fluoroscopic guidance, and then you release the metal stent across the stricture. Part of the stent is outside the stricture into the duodenal lumen, and the part of the stent is inside the bile duct above the stricture. So when ERCP fail, either you are not able to access the papilla or you have accessed the papilla but the ERCP fail because of you are not able to cannulate the bile duct. In this scenario, till now the people was referring the patient for the percutaneous biliary drainage with a high success rate of 87 to 100%. But the problem with the PTBD is you require a multiple session, is a painful, poor patient tolerance, and if patient has ascites or patient is obese, and if you don't have an expertise of PTBD person, then the patient will end up into a problem. So EUS guided biliary drainage is now standard of care, especially for the lower end bile duct. And this is the one case scenario where we started with the ERCP, and what we found, there was a gastric outlet obstruction. We cannot reach up to the ampulla. Just changing the scope, patient is on the same table, same operator, same sedation. You just change your scope to an EUS scope, puncture the bile duct, take the cholangiogram, and once you have done, then you dilate, and after dilatation you can put a fully covered metal stent. If you don't have an EUS facility, this patient next day goes to the interventional radiologist, and patient come up with a percutaneous drain. So I think if you have a facilities of endoscopic ultrasound in the same sedation by the same operator and on the same table, you can do the EUS guided biliary drainage. Similarly, hepaticogastrostomy, if you are not able to do a choledochoduodenostomy because of any reason, then you can take the ERCP route from the liver side, either by doing the antegrade stenting or by doing the hepaticogastrostomy. That is another way of biliary drainage. So as an endoscopist, we can drain the biliary tree by an ERCP, routine ERCP conventional route through the transpapillary route. If you fail, then you don't require to send the patient to the interventional radiologist. You can use the EUS and you can do the choledochoduodenostomy. And if it is not possible, then you can use the transgastric, transhepatic route by doing the antegrade biliary stenting like an ERCP, or you can do the hepaticogastrostomy. Here we are doing the hepaticogastrostomy. A partially covered metal stent was placed and the drainage achieved into the stomach. Now, what is an advantage of EUS guided? As I said, same session, same operator, no additional resources, internal drainage, no pain, not limited by obesity, and it is not hampering the daily activity of patients. Other advantages: short hospital stay, cosmetically better, you can get a tissue diagnosis. If patient has a pain, you can relieve the pain by doing the celiac plexus block, you can manage the gastric outlet obstruction, and the most important, patient is with you, you are the primary care physician, you can tackle this situation. Another common problem is gastric outlet obstruction, and that is again with the help of upper GI scope or the side wing scope. You put a guide wire across the narrowing under fluoroscopic guidance and know the length of the stricture by using the biliary balloon. And once you know the length of the biliary, you know the length of the stricture, then you can put the metal stent across it with the help of endoscopy. So this is one of the case. After putting the wire into deep into the third and fourth part of the duodenum, you put a metal stent. Earlier people was going for the surgical gastrojejunostomy, which is a morbid procedure. Patient is already cachexic and the life expectancy is less. This is not going to take more than 10 to 15 minutes, and it is a non-invasive procedure. Patient can resume his diet from the same day or the next day. But now, with the availability of the better with the availability of better radiochem the life expectancy has gone up, and the metal stent which has gone through the plant's enteral route, most of the time they block. And if it is blocking again and again, you are increasing the cost of treatment, as well as sometimes you are not able to negotiate your wire across the duodenal stricture. In those cases, we can do the EUS guided gastrojejunostomy. What we do, we fill the lumen of the third and fourth part of the duodenum and the proximal jejunum with the water, and under endoscopic ultrasound guided, we can puncture from stomach to the jejunum, and we can put the lumen opposing stent, and that is again going to take few minutes, and you can produce an alternative route. The advantage of this is the tumor ingrowth of the stent is not going to happen. So this is one of the case, and you can see the jejunal loop through this. So these are the two. One is from the Abu Dhabi from the US, and what they have shown that the EUS guided GJ has better, the total requiring the re-intervention was much lesser in the EUS group. And this is another study which was published, and which shows the patient who has a WHO performance score of 1 and 2, it is better to do the gastrojejunostomy. If patient is a 2 and 3, then you can do either enteral stenting or you can do the EUS guided GJ. And if patient has WHO performance status 3 or 4 of the life expectancy is less than 1, then you can do the endoscopic guided drainage. You can do the tumor ablation, especially the tumor ablation of the neuroendocrine tumor of the pancreas, where if the patient is not a surgical candidate, these neuroendocrine tumor of the pancreas can be ablated with an RFA. And what is RFA? Is radiofrequency ablation. It produces a coagulative necrosis, and this is a minimally invasive, can be done with the help of EUS guided RFA needles. These are monopolar or bipolar, and they are available with the Habib EUS RFA probe or EUS RFA by StarMed, which is available in India. These are the needle, which is 19 or 20 G needle with a probe length of 0.5 or 1.5 or 2 centimeter, meaning that the minimum size of the neuroendocrine tumor which can be ablated with an EUS should be around 1 centimeter. And this is the case. You can see a small neuroendocrine tumor of 1 centimeter sitting in the neck of the pancreas. Distal to the pancreatic duct is normal, is close to the SMV, and on Doppler you can see the hypervascular tumor. So what you do, you use the needle and you use the RFA, which produces a coagulative necrosis, and you suddenly see that these insulinoma patient, the sugar level become normal within a short period of time. So this is the needle in, and you generate the RFA generator, and once you start seeing the bubble, that means you have done the adequate coagulative necrosis of the tumor. So pancreatic insulinoma or the neuroendocrine tumor can very well be done. So last, which is important, the palliation of pain, because pancreatic malignancy, the most dreadful complication is a pain, and it's very difficult to control with the medical management. Till now, the people was using the percutaneous method, which has its own complication in the form of organ perforation, paraplegia, or so many complications, and many of the time you are not successful. So EUS guided is preferable, and why? Because you can do under real time, no serious complication, patient is in endoscopic environment, you can do the biliary drainage, you can do the GJ, you can stage the tumor, you can take the tissue diagnosis, and if patient has a pain, you can do the celiac plexus block. And what you do in celiac plexus block is, these are two things, celiac plexus block and the neurolysis. Neurolysis means you are knocking out the celiac ganglia, and that is done with an absolute alcohol. You inject 5 cc of the bupivacaine, 0.25%, and 10 to 20 or 30 ml of the absolute alcohol, 98%. This is the aorta, this is the celiac trunk, and at the origin of the celiac trunk, you inject with the 22G needle or 19G needle around 15 to 20 ml of the absolute alcohol, and that is going to give a pain relief. So this, similarly, you can do the bilateral or direct celiac ganglia introduction. The difference is when you are directing the celiac ganglia, you require 0.5 to 1 ml of the absolute alcohol. You can do the unilateral, you can do the bilateral, you can do the extended celiac block. So that's all. Thank you for the patience hearing. If there's any question, I will be happy to answer.
Thank you. Thank you, sir, for the crisp talk. I have a question for you, sir, regarding the pancreatic ablative therapy. Are there any other modalities that are available for the ablation? And considering sometimes that there is a cost constraints for our patients, is there a possibility of using ethanol as something like a neurolytic agent to be used as an ablative agent for the pancreatic mass?
Yeah, I think it's a very good question. People has used the ethanol as like in the liver metastasis or the liver primary malignancy. The people has used the ethanol as a agent for doing the coagulative necrosis of these lesions. But what I have shown is, number one, the data is limited in the form of case series, but the better results is with an RFA where you are producing the coagulative necrosis, and overall literature for this is less, and it is mainly used for the neuroendocrine tumor rather than pancreatic adenocarcinoma. There are studies and animal studies available for pancreatic malignancy also, but has no good results.
Thank you, sir.
If there are no further questions, we will conclude the talk. Thank you.
Thank you, sir, and thank you, Chairperson. Now we have a case-based panel discussion, acute replacing pancreatitis. For that, I will request Dr. Sanjay Rajput, sir, Dr. Rajesh Puri, sir, Dr. Sukrit Sood, sir, and Dr. Anand Patel, sir, as a panelist. The speaker will be invited by the panelist.
Proceeding ahead with the last our presentation, I would like to invite Dr. Jayanta for case-based panel discussion regarding acute relapsing pancreatitis.
Good evening, everyone. Today is the last talk. I think with a thinned out panelist, and we need to be fast. So I have been given the response. At the outset, I'd like to thank Dr. Yogesh and his full team for this excellent conference with its rich academic content. So I have been given the responsibility of case-based panel discussion for recurrent acute pancreatitis. We all know that what is acute pancreatitis, right? We have defined it. Revised Atlanta has defined as 2 out of the 3 features: typical pain, more than 3 times the upper limit of the normal of the enzymes, or a characteristic imaging findings, be it ultrasound, CT, or an MR, right? So, and the second thing that we know is chronic pancreatitis, where there is an irreversible permanent damage to the pancreas with histological evidence of inflammation, fibrosis, etc. And there are fixed criteria for CT, fixed criteria for US for diagnosing chronic pancreatitis. But what is this recurrent acute pancreatitis? Is it something which is in between acute pancreatitis or chronic pancreatitis? Does it involve both the entities, or is it just a continuum from acute carrying on to chronic pancreatitis? So we'll see what is recurrent acute pancreatitis. This is something which is a very dubious definition. There is no definite definitions about it. So my points of discussion will be how to define recurrent acute pancreatitis, what are the differentials, etiology, diagnostic algorithm, and treatment. My august and expert panelist will help me to go through these points. So we'll come to the first case, a 27-year-old male, chronic alcoholic. He used to binge alcohol a lot. First time he developed a severe acute pancreatitis, managed conservatively, did well, again started drinking alcohol. Second episode after 1 year. Again he had a recent birthday party, he had a binge. This time the severity of pancreatitis was mild. In 2020-2021, the third time when he again had a drink,
they did not show any features of chronicity, but later that year when another imaging was done because of the persistent pain, there were some specks of calcification. So I'll begin with Dr. Sanjay first, that do you think this is recurrent acute pancreatitis? So how do you think we will, I'll start with the senior most person, Dr. Rajesh Puri sir. So what do you think will be the definition of recurrent acute pancreatitis?
So, the definition of recurrent acute pancreatitis is, I think the agreement has not happened yet. But the common definition which is used in the clinical practice is 2 or more episodes of pancreatitis, where between these 2 episodes the pancreatic parenchyma has been normalized in the form of there is no pain. Because the common problem occurred today, there is a pancreatitis, after 1 month patient came with the second episode and we are not sure is it a second or it is an ongoing pancreatitis.
Absolutely.
So there is a pain-free period of at least around 3 months, but you have to rule out any pancreatic collection by the CT scan or endoscopic ultrasound. So 2 or more episodes with a separate interval of the no history of the pain at least for 3 months, and the idea of 3 months is that the pancreatic inflammation has settled out during these phases, and you have to rule out the complication of the pancreatitis in the form of pancreatic fluid collection.
Absolutely. The message is loud and clear, to at least 2. In between there is a gap of 3 months, and definitely there is no residual pancreatic complications or changes of chronic pancreatitis. So this 3-month timeline, as Dr. Rajesh Puri sir has told, it helps to resolve the pancreas to the normal, so we expect that the second attack is a new one or a fresh one, right? So after a single episode of acute pancreatitis, people have shown that the recurrence rate ranges from 11 to 30%. But we do not know whether we are dealing with recurrent acute pancreatitis after multiple episodes starts happening and where it crosses the line into chronic pancreatitis. We're going to discuss that. It is yet to be defined. So my next question will be to Dr. Sanjay sir, is that after 1 attack of pancreatitis, again there is another attack of pancreatitis, and then again another. Does every pain episode after the first attack denote a RAP, or do you want to have some differentials?
I think we have to rule out the chronic pancreatitis if patient is having recurrent acute pancreatitis attack first, and history of alcohol, whether patient is having previous gallstones or not, and we should investigate. So if, as Dr. Rajesh Puri has said, between 2 attacks, you have the normal pancreas on USG previously, and now it has come with again with a severe acute or mild acute pancreatitis. That only by investigation we can rule out that this is a recurrent pancreatitis or this is a second.
Absolutely. So we can have multiple complications of the pancreatitis, which can again happen not only just immediately to the first attack, but it can happen at a protracted course. Many times what happens is, as Dr. Jahangir was telling, that once you start with the pancreatitis, the pancreatic parenchymal damage can progress for a long period of time. So even the first attack can lead to these kind of complications in a later phase, and probably that is the sequel of the first pancreatitis rather than a recurrent attack.
And not only that, you should ask the history of pain in a very scientific manner, because it is not always pain is associated with the pancreas.
Absolutely.
It may be a cholecystitis, it may be an appendicitis. So you should know first, and it may be sometime a venous thrombosis.
Absolutely.
So the nature of the pain supported by the investigation is very important, because patient has a venous thrombosis and mildly raised amylase of around 150. That doesn't mean that patient has a recurrent episode. So you should take a proper history. You should know the nature of the pain. If it is the pancreatic nature of the pain, along with the rise in the amylase lipase, with the supported by the investigation, then you should say, yes, this is the second episode of the pancreatitis.
Absolutely. The point is well taken, sir. So we move along. So once we have known that this is recurrent acute pancreatitis, we have defined recurrent acute pancreatitis, right? So, Dr. Sukri, what do you think are the etiologies of recurrent acute pancreatitis? Is it different or is it the same?
It actually overlaps with the etiology of chronic pancreatitis, because in reality it seems to be a continuum. That's why there is such overlap with the etiology. So what we used to remember as an acronym for the longest time is TIGAR-O.
Correct.
So with T is toxic, so toxic and then the alcohol, smokers or metabolic disorders like hypercalcemia, hyperparathyroidism or hypertriglyceridemia. Idiopathic, very common in South India, especially early onset, late onset, and an entity called tropical, which is fading out, which may be overlap with idiopathic itself. G would be genetic, which is autosomal dominant, like PRSS1, hereditary pancreatitis. Minor genes like CFTR, PINK1 may occur in combinations, especially in conditions like P. division, where they gain importance. Autoimmune, as we said, IgG4 related systemic disease, it comes in the spectrum. Recurrent is somewhat of an overlap in patients who are chronic alcoholics, diabetics, radiotherapy, it's just, I think, a dumping can for Figaro. And obstructive can be benign obstruction, be it a stone, a stricture,
or any kind of tumors,
and a malignant stricture, like we discussed in the last case.
So whatever can cause an acute pancreatitis, whatever can cause a chronic pancreatitis will definitely cause a recurrent acute pancreatitis. I'll go briefly through the main causes will be alcohol and gallstone for recurrent acute pancreatitis, I believe. And the risk will definitely keep on piling up the more and more the patient keeps on binging. So the message is, if your patient is drinking alcohol, tell them to stop it. Smoking, I guess, is another interesting and important risk factor for both chronic as well as recurrent acute pancreatitis. So, and it has been found to be an independent dose-dependent risk factor. So again, smoking is an over and above added risk factor over and above alcohol. So you need to tell your patient to stop smoking. About gallstones, again, gallstone is a very common cause of recurrent acute pancreatitis. So I'll come to the second case, a young female with having developed a pancreatitis. You have this LFT of OTPT 161 and 89. Lipase is elevated. This is a classical acute pancreatitis. You do an ultrasound, you find this is just GP is partially distended, no other calculi. The plan was to again do a repeat imaging 6 months later, and this is what you find on an ultrasound. So the next question will be to Dr. Anand. What do you think you are seeing here, and what is your opinion regarding this?
I think for a surgeon, the most important thing is to rule out the obstructions, and the patient had already a second time episode, and this is a EUS pictures. It shows a hyperattenuating signals, and there is a well posterior acoustic shadows. I think it's relevant for microlithiasis. So that could be a cause of recurrent acute pancreatitis.
So the most important thing is, if you are not getting a proper gallstones, even microlithiasis can cause recurrent acute pancreatitis. The definition is very clear, less than 3 millimeter in diameter. Why this definition has been taken is because less than 3 millimeter, more than 3 millimeter is usually picked up on transabdominal ultrasound. So less than 3 millimeter we usually pick up very, very well on US. So US is one of the very, very sensitive tests, more than 96% sensitivity to pick up microlithiasis. We need to understand, and the audience needs to understand, that microlithiasis and microcrystals, which used to be earlier tested in bile, is different. Microcrystals means that the bile is lithogenic, so it can have a tendency to form stones. But microlithiasis is something which radiologically you can see. Dr. Puri, your opinion, please.
Yeah, so I think 4 important points which I would like to highlight. One is term is called as sludge, which many of the time the gastroenterologists also confuse. Number second is a microcrystals, and one is microlithiasis. So a stone of less than 3 millimeter which cannot be picked on transabdominal ultrasound is called as microlithiasis. But if you have a layering of the sludge, what the sludge is a crystals along with the mucoid material which is in the layer form in the gallbladder, and that is not responsible for the pancreatitis.
Absolutely.
Number third, the crystal what you examine, earlier people was examining the bile taken from the duodenum or from the bile duct and examining under the polarizing microscope. So these crystals are present, but they are not always responsible for the pancreatitis.
Absolutely.
So this is important. And one more thing, I don't know you are going to ask or not, which is I wanted to highlight, very important point. The question always gastroenterologists talk, if patient has a recurrent pancreatitis, do the EUS after 6 weeks. But if you want to pick up the microlithiasis, you should do within 48 hours. Because that is the time when we talk about the SGOT, ALT of more than 2 times upper limit of the normal, we suspect it is a biliary. So to document is it a biliary or not, you have to examine immediately, which is not mentioned, but this is one of the caveat where you can do the EUS examination early during the time of pancreatitis rather than waiting for 6 weeks.
Point well taken, sir. I'll just highlight a few studies. Earlier studies told a lot about microlithiasis because it was all assumption based, not US based studies. Latest US based studies shows that the rate is around 10 to 13%. One study from AIMS I'd like to highlight that they noted microliths. They did a cholecystectomy. In spite of that, 8 out of those 10 patients went on to develop chronic pancreatitis. So we talk about microlithiasis, we talk about recurrent acute pancreatitis, so we expect that once we remove the gallbladder, the recurrent acute pancreatitis should stop, but data suggests that it does not. So what do you think is your opinion regarding microlithiasis? Is it having a role? You want to go ahead with a cholecystectomy or you want to wait?
So I think it's a very good question. So again, the clinical scenario will matter. Number one, if your patient has a acute pancreatitis within 24 to 48 hours, if the ALT level is twice or thrice the upper limit of the normal, and on endoscopic ultrasound you have a microlithiasis, which is typically called a starry sky appearance. Not few crystals floating in the gallbladder while pressing on the right hypochondrium, that is not microlithiasis.
Absolutely.
And one more thing which you can do is you can do the HIDA scan to look for the contractility of the gallbladder. If it is impaired, if there is a starry sky appearance, on the day one of LFT is abnormal, then yes, doing a cholecystectomy is a wise answer. Even in the Dr. Pramod Garg study, as well as there's another study what they have seen, that around 10 to 30% of the patient, they turns out to be a chronic pancreatitis.
Absolutely.
So this is the group where you find an abnormal LFT supported by microlithiasis, you can do the cholecystectomy. But yes, presence of a stone doesn't matter that is a biliary pancreatitis.
Absolutely.
These patients have a recurrent pancreatitis, landing up into the chronic pancreatitis, this is important.
So the message is loud and clear. You have pancreatitis, you have deranged LFTs, and there is imaging evidence of microlithiasis and or stone. You can assume that probably this patient is dealing with a gallstone related pancreatitis, and we go ahead with a cholecystectomy, right? So the crux is very simple. Suspect biliary if LFT is abnormal within 24 to 48 hours of pancreatitis, and you do a US. The best probable modality to detect microlithiasis is endoscopic ultrasound. So the rule of thumb, one more thing that I would like to point out is if a patient has recurrent attacks over a period of 6 months and yet the gallstones are not seen on ultrasound is highly unlikely. Even after 6 months, you keep on repeating imaging, you're still not trying to find out. You can't keep on pushing the patient to go on an ultrasound just because you believe that RAP is because of microliths.
The natural history of microlithiasis is within
by that time it would have
12 weeks they form the stones.
Absolutely, sir. Absolutely. So I'll come to case 3. This is hypertriglyceridemia. I think there is a short of time. So hypertriglyceridemia is another important cause which can cause acute pancreatitis. The probable cause will be more than 500. If it is more than 1000, it's a definite cause of hypertriglyceridemia related pancreatitis. And one important data is that if you have diagnosed hypertriglyceridemia related pancreatitis, you need to bring down the triglyceride levels lower, because the higher the levels are, even in spite of your being treated, if you are not adequately treating, the odds ratio or the risk keeps on manifold for recurrent attacks. This is another important case. I'll ask Dr. Rajesh Puri and Dr. Sanjay Rajput to comment on this. A middle-aged man with 3 distinct episodes of acute pancreatitis, LFT normal, MRCP showing a dilated MPD with this kind of a feature.
MRCP shows dilated MPD with?
MPD in the head, but there was no obvious mass over here.
Okay, I think this is a very good question which my colleague has asked, and this is important for the physician. A dilated pancreatic duct without obvious narrowing because of stone or mass, it is called as IPMN. So this is a main pancreatic duct IPMN which is limited to the head of the pancreas. So malignancy of the pancreas, either a small tumor or an IPMN, can also present as a recurrent pancreatitis. And when you do a side wing endoscopy, you find the fish mouth appearance of the papilla.
But a clause, it could be a Versengo-seal as well.
Yes, it could be a Versengo-seal as well. So some of the points that both the
generally Versengo-seal in the ventral pancreatic duct.
Yes, sir. So some of the points that the panelists have pointed out, one is we need to look for other causes of recurrent acute pancreatitis like IPMN, like ampullary tumors. So these are the things which we need to look into, and if we are trying to find those tumors and those lesions, then we need to call in our surgeons. Point being that these kind of small tumors might be just at the ampulla, which can be very easily missed on CT. So again, US will be at the rescue in order to diagnose these cases. So you should strongly suspect these kind of lesions in any patients with more than 50 years presenting with an idiopathic pancreatitis or idiopathic recurrent acute pancreatitis. We should always be, the suspicion should be very, very high to try to find out these kind of abnormal lesions. This is another case. I'll ask Dr. Sukrit. Young female presenting with focal pancreatitis remaining workup is negligible, and this is what you find on an MRCP. So what do you think, pancreas divisum and recurrent acute pancreatitis?
Alone recurrent acute pancreatitis due to pancreas divisum has not been completely scientifically proven. It works in combination with the current where we are mentally, is that certain minor genetic factors do play a role. They might be heterozygous for SPINK1 and CF1.
Absolutely. So what we believe is that because pancreas divisum, we feel that just because they have not joined, the duct is not adequate enough to drain the duct. That is the logic behind which we always thought that pancreas divisum will probably lead to pancreatitis. But earlier data, that is the reason why it's suggested. But later it has been shown that even in autopsy series where they don't have pancreatitis, there is pancreas divisum, right? So those are the points, as you rightly pointed out, goes against the fact that probably pancreas divisum alone cannot cause pancreatitis. So what all things do you think are needed? This is probably as a cofactor rather than a cause that you want to try to point out. So what are the other additional factors that you think should go along with pancreas divisum to cause pancreatitis or recurrent acute pancreatitis?
So these patients have to be worked up for mutations. You have to run a genetic profile, do sweat chloride testing if the patient has features of lung diseases earlier in childhood, do a sperm analysis as well,
Absolutely.
SPINK1 mutation.
So you're talking about hereditary pancreatitis, cystic fibrosis, or any kind of these kind of gene mutations which can happen, which can coexist with pancreas divisum and lead to these kind of pancreatic attacks, right? There is definitely mixed data, some from outside, some from India, but again the data is not very conclusive, but this is very clear that pancreas divisum alone cannot cause. It has to coexist with some other predisposing factors or precipitating factor in order to lead to pancreatitis. I'd like to ask both our expert interventionists, Dr. Rajesh Puri sir and Dr. Sanjay, ERCP in pancreas divisum, what is your take?
Yeah, as like Sukrit has said that it is sometimes a coincidence rather than the cause of pancreatitis.
So a patient comes to you, sir, straightforward question, a patient comes to you.
I'm giving the answer.
Okay, sir.
So first of all, beside this question, cathepsin B is seen in the 50% of the patient of recurrent pancreatitis with the pancreatic divisum. So genetic marker study is important.
This was the
patient of pancreatic divisum has dilated pancreatic duct. ERCP is the answer, doing the sphincterotomy and putting the stent. Number one. Number two, patient who has, what is the question? Pancreatic divisum with the ERCP.
Pancreas divisum is there, patient is having 2 attacks already the patient had.
So recurrent episode of acute pancreatitis with dilated minor pancreatic, with dilated duct, with the pancreatic divisum, endotherapy is indicated. Number two, recurrent episode of pancreatitis, other causes are negative for etiology. I would like to do, even in the normal pancreatic duct, doing the sphincterotomy and subjecting these patients for the, may get the relief.
Sanjay sir.
Yes, sir. Same, because we have seen that most of these patients, they suffer a lot of pancreatitis attack, and ultimately they will go into chronic pancreatitis. So better to do an therapy which is almost give result in almost 50 to 60% of the patient. So I will go with ERCP if
I agree with you.
2 or more attacks.
Whatever data, retrospective as well as this small prospective study shows that yes, there is some benefit, but again we are still waiting for this trial answer.
Well, the question only comes when you are not sure if this recurrent pancreatitis is because of the pancreatic divisum or not. Is that right?
Correct.
If the PD is dilated, sure shot you have to do the ERCP. If you have ruled out other causes, then it is better to do a sphincterotomy, taking all precautions. It is better if you are not a good ERCP interventionist, send the patient to a place where the good ERCP person is there, put endomethylene suppository, give a ringer lactate, talk to the patient and do the small sphincterotomy that might going to benefit.
Absolutely, point well taken. So for all practical purposes, pancreas divisum with a dilated duct and a pancreas divisum is there, recurrent acute pancreatitis.
Do not try too hard on minor ampulla.
Absolutely.
That is the most important. If you are not good enough, send it to others who are
Send it to better centers for the procedure. This is one of the trials whose answers we are waiting, which will give a better answer about this particular question. So there are other etiologies are there, everybody is aware of that, I will not go through them. Sphincter dysfunction. Patient is having recurrent acute pancreatitis, and then what do you think? Do you think you should cut the sphincter and that should help relieve the pain? There is no other etiologies that you can find out. And there is minorly dilated duct.
Can we assume that it will be sphincter of Oda if there is no etiology? If there are dilated duct if there are enzymes are high, patient have recurrent bilirubin high, which is going to normal, and there are clinical suggestions that this patient may have dilated duct which has become normal later. So we can do ERCP in those cases, or do EUS and see whether there are some hidden stones which are not picked up.
Absolutely,
on
sir.
routine. Yeah.
You did an US, sir, and still you could not find an answer. Then what do you do?
Yeah, I will do if patient has more than 2 attacks with increased bilirubin, increased SGPT during the attack. Yeah, we can do.
Normally what we practice is that the duct remains dilated between attacks. That's when the other factors are fitting, the LFTs are not settling on their own, and because during the episode of acute pancreatitis, you can expect LFTs to rise slightly due to multiple causes, and then you are biased. But 4 to 6 weeks after the episode is over and still that type 1 is obvious. First of all, we don't know whether central aortic dysfunction exists as an entity. So we have to address the elephant in the room. Maybe this is all made up. There's not enough evidence that etiology even exists. But if we get dilated CBD which remains dilated between episodes, LFTs which don't settle between episodes, and there's significant pain, then it's worth a shot to do a symptotomy.
I think pre-test probability of disease is going to decide would you like to do the ERCP or not.
Yes.
If your clinical decision says all other causes are negative, if you fit into the criteria abnormal LFT persisting for a longer time,
But sir, the data suggests otherwise.
And I will tell you another things, then if you are so much biased, then you can do the pancreatic sphincter or biliary sphincter manometry. Then you can do it.
So this is one study which showed there is no difference. This is the episode study which is clearly what Sukrit was pointing out, that SOD3 does not exist. It is not even a pancreatic disease. So we are not supposed to do anything about it. That was clearly answered by this episode trial.
Yeah.
And so SOD is more of an epiphenomenon. That is what we are to believe now as of the data is concerned. We need to understand this is the classical chicken and egg conundrum. Which came first? Did the SOD come first, or because of the inflammation the SOD happened? Meaning thereby whether the papillary stenosis was there earlier or later on because of the inflammatory process or the risk factors that were there, the papillary stenosis happened, which you are thinking about like as an SOD.
Yeah, so only thing is, like I will tell you, clinically, papillary stenosis is going to persist. The PD keep on increasing, CPD keep on increasing, LFT keep on remain persisting. If it is a SOD, then there will be a fluctuation. So this is more theoretical discussion, and such kind of patient you hardly find in your practice, maybe 1 or 2. You don't find a picture of patient that you are going to debate. You hardly find such kind.
Absolutely.
And one more important thing, last is
Yes,
the
sir.
drugs, which I think you have not discussed. Drug causing recurrent.
Yes. Actually, I skipped this slide, so I had mentioned in the slide, yes, definitely drug is an important, there are multiple other causes, hypercalcemia, IPTH related, pancreatitis, drug related, etc. These are there definitely. Quick question to Dr. Anand, what is the approach to a patient presenting with RAP?
I think we have to find out what is the most common cause of this one. If it is a gallstone, do the cholecystectomy. If there is a precipitating factor, alcohol or smoking, ask the patient to quit it. Apart from that, obtain the EUS, rule out the chronic pancreatitis, rule out any pancreatic neoplasm. And if you find not a defined criteria, then take help of your other colleagues and rule out the genetic cause and give the appropriate treatment.
Absolutely, the point is well taken. And we need to understand one more important point is that pancreatitis, acute pancreatitis, around 11 to 32% will progress to recurrent acute pancreatitis. Of that, another 3 to 10% will progress to chronic pancreatitis. One episode of pancreatitis sets the ball rolling. So one episode of pancreatitis can lead to 10% cases of chronic pancreatitis, and 30% of the recurrent acute pancreatitis is eventually chronic pancreatitis. So we still do not know the answer, sir, that we are dealing with what is called a smoldering pancreatitis. Whether it's continuously going on or RAP is nothing but just an early harbinger of chronic pancreatitis.
One episode of pancreatitis leading to chronic pancreatitis in around 10% of the cases. That will depend upon the severity of pancreatitis. It's not only that there's a mild interstitial pancreatitis, the 10% going to be a severe necrotizing pancreatitis.
This is debatable, sir. So this statement is debatable, sir. We all agree that once the duct is completely damaged, I understand your point that there is an obstructive pathology is being set in, as a result of which you are telling that the chronic pancreatitis develops. But again, this 10% also includes things which are not maybe moderately severe.
And around 30% or 32% of patients with recurrent pancreatitis will
go on to develop chronic pancreatitis.
Only the 2 papers are, one is from AIG and one is in Gastroenterology 2014. I think these are 2 data which is available to support we are talking on the basis of 2 papers, I think.
Correct, sir.
But I think etiology will play a role as well. Idiopathic and alcohol.
Absolutely, absolutely. Will play a much significant role as compared to.
And one more thing, people talk, I'm taking less amount of alcohol, why I'm developing the pancreatitis.
Yes, yes.
But many of the time mutation, they also play an important role. In that case, the small amount of alcohol is also dangerous, and that can produce a recurrent pancreatitis.
So I'll go very fast to the investigation levels. We all know we do basic investigations. Level 2 will be an US and an MRCP. And level 3 will be, if you are still not able to find out answers, we'll go for genetic mutations, etc. One quick question to Dr. Rajesh Puri sir is that what is the role of EUS in idiopathic recurrent acute pancreatitis?
So I think it's a very good question, and the question is very close to my heart, and you have given answer to this. The role of EUS can detect the early chronic pancreatitis, that is the result of Rosamond criteria. The only point you should again remember, a patient who is 65 in India, who is smoker, you may find the changes. So Rosamond criteria define the major and the minor, which is very good for picking up the early chronic pancreatitis. Most accurate for identifying the macrolithiasis, there is no confusion. It is better than MRCP for the stone of less than 5 millimeter. MRCP specificity and accuracy goes down if the stone size is less than 6 millimeter, or a stone which is impacted at the ampulla or vetter because there is no fluid. So MRCP cannot pick up.
So the crux of the whole issue, I guess, is that you perform the US to determine the etiology of recurrent acute pancreatitis, give the pancreas time to settle. So at least 2 to 3 months gap has to be given so that the acute inflammatory processes settle down. Only then it is better to interpret the results. What do you think?
Absolutely. The only thing is, if patient is in the cholangitis, or as I said, we wanted to discuss about the macrolithiasis finding, especially about the macrolithiasis.
Absolutely.
Yes, then time is important.
Point well taken. MRCP is another added thing which will definitely give a lot of information about the ductal anomalies, etc. SOD manometry we don't do nowadays. Genetic testing, what do you think, Dr. Anand, genetic testing, should we be doing it?
I think that those patients who are getting frequent attack of that, and we are excluding all the causes, and we are not finding the better to find out the cause.
I guess yes, we need to find out whether there are additional risk factors. Genetic counseling will help, but sometimes what happens is, since you can't do anything about it, it adds to the psychological burden on the patient as well. So it's like a kind of a double-edged sword for genetic testing. But yes, definitely hereditary pancreatitis and cystic fibrosis, these two will definitely be something, because we need surveillance for that. We need other additional treatments for that. Dr. Sanjay, what is the therapeutic approach in patients with recurrent acute pancreatitis? Patients come recurrent acute pancreatitis, you find out whatever has to be done.
As we discuss, if evidence suggests it is biliary pancreatitis, we do ERCP. If it is chronic pancreatitis already presenting as acute pancreatitis, we do ERCP.
Yes.
But in case of SOD, we may or may not do if patient is having recurrent attack. We discuss with the patient about the failures and the chances whether they are getting result or not.
And the last is my take on for genetic counseling is in the positive way. Because people says when there is no treatment, why to do it? My thought process is different.
My question to Dr. Rajesh Puri sir, sorry to interrupt you. Patient is coming with recurrent acute pancreatitis, you are not able to see any microlithiasis, anything. Do you suggest the patient, let's cut the bile duct sphincter and then see whether it is responding or not, sir?
Let's
cut the bile duct sphincter.
No, if you don't have a diagnosis of the biliary pancreatitis, you should not do it. And the last thing which I was talking about, the genetic thing, I prefer to do it, especially patient has a pancreatic divisum and you are not suspecting, then genetic, if patient has a cathepsin B positive, then yes, the probability of that is there. Young patients, you want to prognosticate. Number third, patient who is taking, you can advise them not to take alcohol. You can tell them not to take the smoking, because these are genetically predisposed individual for the pancreatitis. So genetic testing is not that bad, which is written in the literature, because they says when you can't treat it, why you want to do it? But you can prognosticate these patients. I think if it is not very costly, and I inquired from AIG, it is going to cost 4,000 or 5,000 rupees. Is that right?
Another issue is, I think preconception counseling is very important.
Absolutely. Yes. So remaining cholecystectomy, yes, definitely it should be in proven biliary pathology, we go ahead with cholecystectomy, but empirical cholecystectomy where there is no evidence is definitely something which should be discouraged. Medical therapies, what do you think about UDCA, ursodeoxycholic acid? Should it be given? So ursodeoxycholic acid earlier was thought to have some benefit with microlithiasis, but again there are two studies, I think both from India, one from DC Sharma way back in gastroenterology in 1998, but these studies were very, very small in sample size. They probably gave a report in favor of UDCA, but we still do not have any evidence. What about POT, sir? Patient is having recurrent acute pancreatitis, recurrent attacks patient is having. Will you give pancreatic enzyme replacement therapy to these patients?
I don't give. I don't give.
Yes, Sukrit?
Proven exocrine insufficiency only.
Yes, definitely you are going to give.
Absolutely.
If there is a proven exocrine.
Empirically POT giving to recurrent acute pancreatitis is something which has very, very poor evidence, and the same holds true for antioxidants, because antioxidants is more for chronic pancreatitis, not for acute. So I'll summarize that RAP is a syndrome less understood with complex overlapping pathophysiology. The data is still scarce and evolving. Though the evaluation of the thorough evaluation, if you do it, 70% will have an answer. Pancreas divisum cofactor rather than causative. SOD probably an epiphenomenon rather than an etiology. And role of genetics definite, but more data is needed. One attack of pancreatitis, you set the ball rolling. It is your job to save the patient with the appropriate advice. Thank you. And thank you the panelists for an excellent discussion.